Good morning, one and all. On this April 1st, 2025, we'll call to order the SB 882 Advisory Council on Improving Interactions Between People with Intellectual and Developmental Disabilities and Law Enforcement. Madam Parliamentarian, would you please call roll to establish a quorum?
Thank you, Chair Frazier. When you respond as to your presence, please identify whether or not there's anyone under the age of 18 with you. To that point, I'm going to go ahead and get started. Members of the council, as I call the roll, I will begin with the chair, the vice chair, and then continue alphabetically. Chair Frazier.
Nobody present under 18.
Chair Frazier is present. Vice Chair Zuniga.
Present. No others present with me.
Thank you. Vice Chair Zuniga is present. Member Brazil.
Present and no one under 18.
Member Brazil is present. Thank you. Member Brown.
Present. No one here under 18.
Member Brown is present. Thank you. Member Burt.
Present. No one else is here with me.
Thank you. Member Burt is present. Member Libero.
Present. No others are here with me. Thank you.
Member Libero is present. Member Petarudu.
Present, and there's no one else in the room with me.
Thank you. Member Petarudu is present. Member Phillips. Member Phillips. Member Phillips is absent. Member Tingarides.
Present, and there's no one else in the room with me.
Thank you. Member Tingarides is present. Members of the council, there are 9 members on the advisory council, and the number required for a quorum is 5. The number present is 8. A quorum has been established.
Thank you, Madam Parliamentarian. So let's move forward with some short remarks. Once again, I can't thank each and every one of you and staff for making the effort to be here today, and want to make sure that we are timely and get through our agenda in a swift manner today. Hopefully, all of our technical issues are over with, especially mine. And so with that, I would like to again welcome everybody and thank them, and we'll move on to agenda item number 2, which is the approval of March 6th, 2025 meeting minutes. Do we have any comments or suggestions, or would like to pull an item on the agenda for the meeting minutes?
I'll make the motion to approve. This is Vice Chair Zuniga.
Perfect. I have a second.
I will second Member Burt.
So we have one a motion, and first by Councilmember Zuniga, Vice Chair Zuniga, and a second by Councilmember Burt. Madam Parliamentarian, would you please call the roll call vote on the meeting minutes for approval?
Thank you. Members of the council, it has been properly moved and seconded to approve the minutes as presented. I will call the roll for the vote. I'll begin starting with Chair Frazier.
Aye.
Chair Frazier votes aye. Vice Chair Zuniga.
Aye.
Vice Chair Zuniga votes aye. Member Brazil.
Abstain.
Member Brazil abstains. Member Brown.
Aye.
Member Brown votes aye. Member Burt.
Aye.
Member Burt votes aye. Member Libero.
Aye.
Libero votes aye. Member Petarudu.
Aye.
Member Petarudu votes aye. And Member Tingarides.
Aye.
Tingarides votes aye. I will call to see if Member Phillips is present. Mr. Chairman, there are 8 members present and voting. There were 7 ayes, 0 nays, and 1 abstention. The motion passes.
Thank you for that. Action item number 2 on the agenda has been passed by roll call vote. We'll be moving on to agenda item number 3, public comment. Is there anybody in the queue at this present time, either present or
I'm
in
sorry,
the queue?
Mr. Chairman?
Yeah.
Excuse me, the public comment is set for 9:25. We'll have to come back to it at that time.
Oh, you're correct. Again, I'm trying to roll through this. You're absolutely correct. I apologize. We're gonna move on to, and when 9:25 does strike that witching hour, we'll be moving back to the public comment. But for now, we're gonna move on to number 4, discussion item with the DOJ updates on 1, conflict of interest waiver, 2, pending legislation, and also number 2, training evaluation. Take it away, DOJ staff.
Good morning, Council and members of the public. This is Ben Conway, the Deputy Attorney General with the California Department of Justice. I'll be addressing the items in Agenda Item 4, beginning with the waiver comments. I was able to speak individually with many of the council members, but we wanted to address the council broadly about the waiver and the public as well. At an earlier council meeting, the council posted a question regarding whether there is any conflict of interest in council members providing trainings to law enforcement officers while serving on the council in light of the DOJ's incompatibility statement. For background, upon joining the council, members signed DOJ's incompatibility statement. Among other things, that statement prohibits outside work or reimbursement for tasks related to their work with DOJ. With respect to this council, that statement could be read as to bar council members from providing training on the subject of SB 882, namely law enforcement interactions with people with mental health conditions and intellectual or developmental disabilities. DOJ has now granted a waiver to council members of that provision in order to permit the advisory council to both fulfill its statutory mandate of evaluating the trainings available to law enforcement, while also ensuring that council members and their employers are not barred from providing training, sharing their experience, or doing their jobs. This means that council members are free to provide trainings on law enforcement interactions with people with interactions with people with mental health conditions or intellectual and developmental disabilities. I'll pause here to see if there are any questions on the waiver before moving on to the next topic.
Any thoughts from the council or questions of staff?
Okay. Next is the legislative update. The legislature is currently in session and very active. We're sharing 3 bills that may be of interest to the council. First is AB 308. I'll say that again, AB 308 from Assemblymember Ramos. This is mobile crisis teams or units procedures. This bill, in the case of a county that operates or contracts for the operation of a mobile crisis team or unit, would authorize the County Department of Behavioral Health's director to develop procedures for the mobile crisis team or unit that include the handling of an emergency situation or a crisis incident involving an individual with an intellectual or developmental disability or an individual with a behavioral health condition. This bill would require the procedures, if developed, to address certain items, including de-escalation techniques. The bill would authorize directors to develop training in conjunction with law enforcement for those procedures. AB 308 was re-referred to the Committee on Human Services on March 4th, and a hearing is pending. Second is AB 1013. AB 1013, Assemblymember Garcia. This is on peace officer training for behavioral health. This bill would authorize the Commission on Peace Officer Standards and Training, or POST, to partner with local departments of behavioral health, community-based organizations, or nonprofit organizations to establish and keep updated this classroom-based continuing training course. The bill would require a law enforcement officer with a rank of supervisor or below and who is assigned to patrol duties or to supervise officers who are assigned to patrol duties to complete the course. AB 1013 was referred to the Committee on Public Safety, and there is a committee hearing scheduled for today, April 1st. Third is SB 664, SB 664. And I apologize, I believe it's Senator Bowe, B-O-G-H. This is on vehicles, public safety, the Blue Envelope program. This bill would, by January 1st, 2027, require the DMV, in consultation with relevant stakeholders, to develop a Blue Envelope program. Under the program, the bill would require the Blue Envelope to contain specific information for requesters with a condition or disability as specified. The bill would also authorize others, including a parent or legal guardian of a passenger with a disability, to request a Blue Envelope. SB 664 was referred to the Committee on Transportation on March 5th, and the hearing is pending still. I'll pause here again to see if there are any questions on the legislative update.
I will just give you an update, Ben, that 308 was pulled by the author in the last hearing. And I wanted to let you know that I had talked to the consultant in that committee recently, sharing the duplicative nature of the bill to 882. And so they're holding it and researching it a little more if they can have a nuance that augments 882. But as of now, they pulled the bill.
Okay, thank you for that update, Chair. Does anyone else have questions or comments on the legislative update before I move on? Okay. My final update to the council and the public is on training evaluations. We've reached out to over 24 agencies that train law enforcement officers. These range from independent for-profit and nonprofit agencies, police departments, sheriff's departments, and academies. And we've begun scheduling some of those trainings directly with council members who are available for those trainings, given the location and the timing of the training. We have many more agencies in the pipeline, and we'll continue working directly with the council so that you all can complete as many training reviews as possible by the end of June. So I know that is a brief one, but we did want to circle back on it. Does anyone have questions on that or or other questions from the first two updates that have percolated? Okay. Not hearing any at the moment, Chair Fraser. That was my update to the council on those 3 items for agenda item 4. Thank you all.
Thank you, Ben. I think what I'd like to do is get your counsel. We have 5 minutes before public comment. And I'm not wanting to interrupt the panelist on the next discussion item. And so if it's okay with staff and the council, I'd like to be able just to take like a 5-minute break to catch up on time and then come back live. Or we can just stay on it for 5 minutes and go from there. So I'm looking for counsel.
I could also provide item 16, our update on the survey. That could take maybe a minute.
If you can stretch it to 4, I would appreciate it. So please, let's move to item number 16 for an update from Councilmember Libero.
Okay. So since our last meeting, the law enforcement agencies survey, this is the survey that has questions for law enforcement agencies in California related to their trainings, so the types of trainings they're doing, and their feedback on the content and effectiveness of those trainings, as well as questions about their resources. So training resources and resources related to response. So things like co-responding teams, CIT teams, things like that. So the survey questions were finalized, the team had tested them, and Councilmember Burt and I reviewed and tested the survey as well. And then we gave final approval for the release. So the survey focused on the trainings related to people with mental health conditions or intellectual and developmental disabilities went out. The DOJ staff sent the survey out to approximately 450 California law enforcement agencies. They sent the survey, an explanation, and the background for why we were sending the survey and why it was important to receive a response. And then I believe they also sent a couple reminders to make sure people found time to fill it out. The survey closed and we received 156 responses. So 156 different agencies responded, which is a 34% response rate, which well exceeded our anticipated response rate of around 20%. So we actually got better response than expected, which is fantastic. Now the DOJ staff and the survey committee will be reviewing the responses from the survey, and the DOJ research services team, from their first review, they believe we have a large enough sample size that we could draw generalizable summaries, so we can put some statements in our report about the statewide landscape of training and law enforcement resources. So after this meeting, the research services team is going to continue their review of all of the responses. They'll be analyzing the data for us, and for our next meeting in July, we should receive a detailed update on the responses and the summaries. So any
Thank you for that.
questions? Okay.
Seeing and hearing, thank you so much for that update.
Great.
And
Yeah.
and appreciate both of your time that you're putting into this. This is going to be very helpful. Have some congratulations on the
Yeah.
return rate. That's
And
amazing.
our gratitude to the research services team from DOJ. They invested a lot of time and effort into putting together the survey, making sure it flowed really well, and then doing the outreach to the agencies. I mean, they just did a phenomenal job. So definitely thanks from the council to them.
Absolutely. Thank you so much for that report. We have 9:25 now. We're going to move into public comment. And I'm going to check and see with staff if there's anybody present or in the queue for public comment.
Chair Frazier, there are attendees. We ask that you use the raise hand function if you would like to make a public comment.
I can also read the introduction while we wait in case anyone's
Yes, please.
on. Good morning, everyone. My name is Kelly Burns. I'm a Deputy Attorney General with the Department of Justice. The legislature's SB 882 Advisory Council would like to hear from you. Today's public comment period will be for 20 minutes, and each person will have 3 minutes to speak. Please be advised that in fairness to everyone, at the 2-minute mark, you may be politely interrupted. However, please know that there is a couple of public comment period during each meeting, and the Advisory Council encourages you to participate. In addition to or in lieu of making comments today, you may also submit written comments at any time via email at sb882@doj.ca.gov. Again, that's sb882@doj.ca.gov.
Chair Frazier, we have a guest who would like to speak.
Hello, can everybody hear me?
Yes, we can. Your time is starting.
Thank you. My name is Jessica Kramer, and I'm the founder of Reach SD Senior and Disability Advocacy. We're based in San Diego, and we developed entirely in response to 911 interactions with people with disabilities. We are made up entirely of people with lived experience and also with disabilities. And we've been fortunate enough to be intimately involved with our law enforcement down here. We work as disability liaisons to several of our law enforcement agencies. And I'm also on the county committee for persons with disabilities, as well as the Behavioral Health Advisory Board. One thing that I've learned is to study police policy and post mandates. And the policies for people with mental health disabilities are very different than the policies for people with intellectual and developmental disabilities. Several of our law enforcement policies still refer to people with mental health disabilities as mentally disordered persons. And the policies are not updated to the type of quality of conversation we're having in meetings like this today. So one of my areas of recommendation, and forgive me because I'm coming in new and I still need to learn more about what you have done in past meetings, but I think a really valuable addition to the work you're doing is to really look at the law enforcement procedures and how the response is very different for people with intellectual and developmental disabilities than it is for people with behavioral health conditions. In my experience, people with mental health conditions are routed very quickly into 72-hour holds or mental health crisis calls. And unfortunately, Medi-Cal eligible individuals don't have access to therapy or trauma therapy anymore. So that routing into the behavioral health system is very, very heavy on involuntary medications. And my organization has become well known to advocate for people who have become permanently disabled with speech impairment, mobility impairment, and other extrapyramidal symptoms as a result of these involuntary holds. It really devastates the community when this happens because the burden of care rises dramatically. And unfortunately, that burden of care doesn't tend to reflect in more accommodations or more protections. It actually tends to result in less in our experience. We're really interested in seeing a more dignified response around mental health that includes improving ADA accommodations.
She continue, please.
Yes.
Thank you so much. We are making strides with things like the Blue Envelope program, but the Blue Envelope program is voluntary. It can't be scanned as a QR code or anything. We find many of our people get caught in situations where they just don't have their Blue Envelope materials. As well, we've noticed that people with mental health disabilities are not considered under the senior and disability protections, such as the Senior and Disability Justice Act, the senior and disability victimization policies that are mandated by post. So thank you so much for the work you're all doing here today, and I look forward to learning more and participating more.
Thank you. Do we have any other guests who would like to do public comment? Chair Frazier, there's no one at this time raising their hands.
Okay, thank you for that. So what we'll do is just leave the public comment open like we did in the last meeting and just run parallel discussion item. If somebody does come in, unfortunately, we'll go ahead and pause the panelists for the comment. That being said, we got to make sure that our panelists are available to step in at this time also.
You know, something we can do is we can do the, we can talk about the report. We can move that up from the afternoon.
Which item is that?
That is item. It's item 17.
Sure. Let's move forward to item 17 and then we'll back up to item 5 when we complete this. Please proceed on item number 17.
Okay, that's, can everyone hear me okay? Okay, great. And before we start, Ben was going to make a screen share available so we can all look at it. And this was set for the afternoon, so I want to give Ben a second to get his computer ready if it's not ready. All right, he's on it. Great, so you'll see the outline is presented on screen. As you recall, last month, you approved a draft outline for the report, a very high level one, and delegated authority to DOJ to continue working on developing a draft report. Today, we'll review a more detailed outline to discuss so that we, like the last time, are able to include the council's feedback and ideas throughout the various stages of the process. We produced this draft outline. We've shared it with you all and with the public prior to the meeting. I hope you all had a chance to review it. I'll remind you all that just as last time, this is a draft. The report belongs to you, and we're here to help and support your report. So the draft is provided to have something to work off of, but you should always feel empowered to make whatever changes, large or small, you would like to make. I'll describe how this draft is organized. As I said, it's more detailed than the last one, so I'm not going to read the whole thing. I think what I'll do is I'll just sort of we can see it on the screen. I'll pause over, and talk about like the broad topics that are listed there, and just sort of for each page give some space for folks to chime in with any thoughts of edits or additions or changes that you'd like to make. Again, like last meeting, what we're trying to agree on today is a working draft. This doesn't mean that we can never make changes again, but rather that this is the outline that we'll work from at this point to continue our research to do early drafting. The next product you'll receive from us will be a more fully fleshed out draft in a more narrative form that reflects the research and the witness testimony that the council has received up to that point. We'll be able to bring in information that further witnesses present in an ongoing way, and we'll also later on bring in the survey results and the training evaluation results as that analysis comes in from our research team. So just to get started, let me switch my screen. Start off with the executive summary, which will be figured out later. Then we have the summary of the key provisions of SB 882. I think maybe I don't need to spend too much time on that unless there's something that I'll just take a minute if anyone wants to say anything else about SB 882 in the introduction other than the sort of basics that are already there. Hearing nothing, I'll move on. Then we also talk about the council membership, and a description of the process. Again, probably not too many changes needed there. Methodology and limitations will include literature review and the various pieces of what our process have been, and we'll add a summary of recommendations at the end of that introductory part. Moving on to part 3. This is the part about the rights of individuals with mental health, intellectual, and developmental disability, listing the existing training requirements that previous bills have put into effect, as well as the federal legal framework and the California legal framework, both of rights and somewhat of the systems, like the regional center systems that come out of the Lanterman Developmental Disability Services Act, to the 5150 system, like sort of basics. We'll come back to that again and when we talk about systems of care, but we'll also talk about it, highlighting the rights pieces of it in this earlier section. Is there anything else that you all would like to see us go into in this part 3 of the outline?
This is Councilmember Burt. Our previous public speaker referenced the Senior and Disability Act, which was Senate Bill 338 back in, I'm trying to find a year. Can we add that as well? I just want to make sure we're getting a comprehensive sweep of any training or requirements for individuals with intellectual, developmental, or mental health disorders. Thanks.
Can I break in here really quick? The ASL interpreters just sent us a message to see if you could kind of slow your speaking down or speak a little slower so that they can have an opportunity to interpret everything that you say.
Of course.
Thank you.
And also, we did say that we wanted to periodically remind folks how to access that interpreter. We'll have an ASL interpreter online all day. There's a little world icon on the bottom. And if you don't see the little world icon, you should click on the 3 dots that say more, and you should be able to get to it. Turning back to the outline. Any other thoughts about this section? We can move on, and we can always come back to things if something comes to you later. Part 4 is the current state of care for persons with mental health challenges and IDD and their interactions with law enforcement. And then we'll talk about first the mental health care system, and then second on the next page is the system of care for people with IDD. Under mental health care, and they're both sort of parallel the way we organize them. We start out talking about relevant demographics, so the prevalence of certain conditions, how the demographics intersect, different populations that may have either higher rates of certain mental health issues, or to the extent that we have any data that say higher rates of interactions with law enforcement when they have such mental health issues. I think that data is somewhat limited, which is some of the aim of SB 882, of course, is to increase that as well. But we'll look for what there is and any co-occurring conditions. Talking about the community-based systems that people with mental health issues are interacting with. And also with an eye to how law enforcement, what resources law enforcement will have to interact with, and the recent reforms, the Prop 1 reforms that are in the process of being implemented. And Lanterman Petrus Short, which establishes the 5150 system, which of course is a place where a lot of these law enforcement interactions come. And then we also we've talked a little bit about looking at mental health care and confinement and thinking more, this is an area we'd like to have some witnesses in the future, but haven't yet, about mental health care in various conditions of confinement and how people are interacting with law enforcement, including corrections officers under those conditions. So is there, let's take a minute for any thoughts or additions or changes that you'd like to see to this part?
This is Councilmember Burt again. And I'm not sure, so I'm going to speak about a little bit of knowledge I have. I know that there's also, when you were going down to the 5150 area, yes, that are we going to be talking about voluntary treatment options here as well? Or is it only involuntary? I've heard that other counties have more resource available for voluntary placements than maybe other counties, and I didn't know if that's going to be in the conversation here.
Yes, I was thinking of that more under the previous section, the community-based systems section, which is a little broader and focusing on in the LPS section on specifically that 5150 system. Though if you have any specifics that you feel like.
Yeah, just maybe something that can call out emerging practices or best practices in a variety of settings, that would be great.
And this is Dagben Conway. I'm just going to flag to folks, if you see the red line on the side of the screen, I've enabled track changes to make it easier for us on the back end to track what was added. So it will look, I'll just click it so you can see the difference. Instead of having to see this, we can just look at it as a clean document, but that will help signal where there are changes.
Is there any component in this that would provide direction or a path for funding for any of this being implemented? You know, you mentioned Prop 1 here, but is that a role that we could undertake so that we make sure that, I think I've mentioned this before, it's great to put people advice and mandates in place, but if they're unfunded, they don't get done. And so I think that is kind of a role that hopefully we could provide some guidance in that area.
Yeah. So are you thinking maybe something like add a category under the community-based systems or elsewhere, or maybe its own category? We can talk about what's best. Potential funding streams to consider or to connect with. And it's something we could also discuss under your recommendations when we get to that part. But it's sort of for this part, are you thinking more of a like, what's the landscape we'd have to think about when considering funding recommendations?
And I think talking to the relevant agencies on that, where they have more of a kind of a background of what they have in their line item that would address what we're trying to accomplish. Or would it be, just a formal budget request that is included in our report to be able to fund? So I'm just thinking that we go through all this work. I just don't want this to sit on a shelf, and I've seen this happen before. So I hope that we can definitely make some kind of provision.
This is Dagben Conway again. Chair Frazier, under lowercase Roman numeral 3 III, funding considerations, am I capturing what you're describing at a basic level?
I think so. I mean, at a basic and like I say, I think, members on our council also that are in law enforcement have some good thoughts about where to possibly engage in that also, through their perspective. But obviously agencies that are directly related to what we're trying to do, I'm open to any other member of the council jumping in with their thoughts, please.
This is Councilmember Vice Chair Zuniga. In regards to what you're saying, the first thing that comes to mind was like when I worked on AB 911, the Manny Alert Act, and they did the feasibility study and they found the potential funding to come from a previous bill, right, where there was the surcharge on cell phone bills, right, and it had the ability to go up. some of that could fall under the different types of community-based programs or systems and our potential recommendation for funding stream, right? Because they have the ability to go up to like 80 cents and it's only at 30 cents right now or something. So making recommendations like that, I see your train of thought.
No, I think that's wonderful, and I appreciate that that advice. I think that, you know, that is paramount for us, all this work for it to be successful.
Councilmember Brazil has a hand.
Yeah, in the considerations, and I appreciate the comment from the chair and vice chair. We should look at considerations in several different areas. One is funding. Secondly is availability of training. Training in the major metropolitan areas, San Diego, Los Angeles, Sacramento, is a lot easier than training for someone who's in Mono County or some of the remote areas. So that's a consideration. And then the third area is staffing. And again, the larger agencies in the metropolitan areas, it's a lot easier to train than it is for someone who's in the remote areas. So I think the consideration needs to be in those three areas: funding, access to training, and then staffing. And one last comment on that. And with access to training, what's available on the with virtual training, so folks don't have to travel, you know, what's already out there, what can they do online versus where they need in-person training.
And I think there should be some kind of an accountability component, that this has actually been in some kind of dashboard developed that shows that it's been accomplished. What you know, we put in line there. And I appreciate what Councilmember Brazil is talking about. He's mentioned this before about the rule. It is very imperative that there's a level of consistency that goes across, and identifying the differentials of how it can be implemented. You know, so I really do think you know, there's a lot of things get pushed up into the legislature, and then once it's passed, you know, they gavel down. There's never any kind. There's a lot of the time there's nothing that really creates that accountability that it was accomplished, or that it needs to be continued in some form or fashion.
And this is Dag Ben Conway again. This question is actually for my colleague Kelly, who knows the outline better. I've added the council members' suggestions here, and maybe this is a better discussion later, but should they be elsewhere, or is this the best place to add them for now?
Yeah, I was wondering that too. I think maybe we can add, as we look at later sections, we can think about moving it down if it makes more sense there.
Okay, this is Dag Ben Conway. Just in case it doesn't stay on screen, I'm going to add a comment to those three to that effect that we just discussed.
Also, a quick process point. We're now, I feel like this is something that we can kind of keep coming back to. We do have the presenter scheduled for 10, and we have a break scheduled before. So should we maybe pause and take the break and then come back to this discussion after the presentations? And, you know, if we do this part broken up where there's time, that I think that is okay. If that is okay with you all. Oh yes, we need to close public comment as well. Yes. Does that approach make sense? I see.
That works for me. I mean, I'm seeing a lot of nodding heads.
All right, great. Let's do that. So we can pause this. I will read the closing reminders about public comments. Is there anyone else who's present who wants to make a public comment? There is no one present at the in-person location.
No one has made their.
Right, no one has raised their hand,
No
so
one.
I'll just remind everyone. Thank you all for the comments. We have reached the allotted time. If you are not able to complete or provide a comment, the advisory council invites you to attend future meetings listed on the SB 882 website at www.oag.ca.gov/SB882, or to submit written comments to SB882@doj.ca.gov. I will now turn the meeting back over to the chair.
Thank you so much for that. And thank you to our member of the public that made the comments, public comments. That was informational, and I appreciate you keeping, I hope that you can keep connected with us through these meetings. We are a little bit ahead of schedule for our next discussion item number 5. I'm going to ask staff if our panelists are present, or if we can bounce another item for about 8 minutes to go forward. Staff recommendations.
I think we have a break unscheduled. Do folks want to take a 5-minute break and take care of any needs and then come back?
I think that's a wonderful idea. So I'm going to adjourn the meeting at this point in time. We'll come back in 5 minutes, which is 9:58, and we'll then reestablish a quorum. Thank you. Welcome back, everybody, from our break. Let's see what we got on the. Give a couple seconds for people to.
It's now 10 o'clock. And the advisory council meeting of April 1st is now reconvened. I will call the roll to, beginning with the chairman, to reestablish a quorum. Chair Frazier.
Here.
Chair Frazier is present. Excuse me, Vice Chair Zuniga.
Present.
Vice Chair Zuniga is present. Member Brazil.
Present.
Member Brazil is present. Member Brown. Member Brown. Member Brown is absent.
Yes, I see Member Brown.
You said Member Brown, I'm present.
Oh, I'm sorry, I didn't hear you. Member Brown is present. Member Burt.
Present.
Member Burt is present. Member Lavero.
Present.
Member Lavero is present. Member Helarudu.
Present.
Helarudu is present. Member Tingarides.
Present.
Tingarides is present. Excuse me, there are 9 members on the advisory council, and the number of members necessary for a quorum is 5. The number present is 8. A quorum has been reestablished.
You're muted, Chair Frazier.
Pardon me?
Thank you for that. We do have a quorum, and we'll move on to agenda item 5, which is a discussion item, a presentation on criminal justice involvement among individuals with serious mental illness and some potential solutions. Our panelists are Dr. Michael Compton and Dr. Amy Watson. Thank you very much for our panelists to present today, and please, at your readiness, please start.
All right, I think. Thank you so much for having us. We're delighted to be here. We're going to present for about 40 minutes or so. I'm going to start the presentation and go for about 20 minutes, and then my very close colleague, Amy Watson, will speak for about 20 minutes, and we'll make sure we have plenty of time for questions and answers and your comments and thoughts and any insights that we might be able to provide. So to get started, Amy, I'm going to let you move through our slides. This is sort of the problem that our research over the past 20 years or so is really trying to address. the over involvement among people with serious mental illnesses. This is sometimes called criminalization, but it's really the over-representation of people with serious mental illnesses, what we'll refer to as SMI, across all facets of the criminal legal system. And there are multiple causes for this criminal justice over-representation. Some of them include not enough accessible mental health services, a crisis response system that involves police, the fact that many people with SMI have comorbid substance use disorders, which we know increases risk for criminal justice involvement, and many other drivers, including the fact that law enforcement is commonly used for transport between mental health facilities, for example, which is a form of criminalization. And importantly, the fact that our patients with SMI tend to miss their appointments because of their psychosocial circumstances and their psychiatric illnesses. And so they commonly miss appointments, and that includes court appointments. And so failure to appear to court is a big problem, as is probation violations, because, they tend to miss appointments. We know that people with SMI have a high prevalence of involvement with the police contacts. And we also know that people with mental illnesses are more likely to be killed by police during police interactions. And so, there's been a lot of research and policy and program planning over the past 20 years or so to try to shift more and more of the care for people with SMI to the mental health system rather than the criminal legal system. We all, know the concerns about mass incarceration among especially African American men. And so that can serve as sort of a double whammy for people with SMI of color. So let's see. As I mentioned, there, is an over-reliance on police as, the major players in crisis response. A lot of work is being done right now to shift that back over to the mental health and social services system. We need to do this because criminal legal involvement reduces our patients' opportunities for recovery, and it puts them into repeated cycles of criminal justice involvement, in and out of jail, in and out of probation, etc. We also know that people with serious mental illnesses have heightened vulnerability and stress during police encounters. This is in part because they've had many police encounters in the past, many of which didn't go well. And so that can change the way that they interact with law enforcement officers, in their next interaction. And we know that once people with SMI enter the system, they stay longer. They stay longer in jail, they stay longer under court supervision, they stay longer on probation. We also know that law enforcement officers don't really want this as part of their job function. They would rather other sectors be in charge of crisis response for people with mental illnesses. They feel that they receive too little training in this area. They want more tools beyond just executing an arrest or transporting someone to an ED. And they feel that the mental health system is deficient in offering inadequate follow-up. It's not uncommon for them to drop someone off at a psychiatric ER, and they say that the person is back on the street corner before the officer even is back on patrol. And they also feel that families need better forms of support as well, in addition to the individuals with SMI. So we've done some research on what our patients with SMI get arrested for, and I'm going to walk through two studies. But first, just a little background information. As you all might know, there are about 10 million arrests each year in the U.S. Most of these are for low-level offenses. And among people with SMI, these are commonly minor misdemeanors that are so-called quality of life crimes or public nuisance charges. But nonetheless, such arrests can lead to criminal justice entanglement and interfere with treatment and recovery. And so we did one study in Southeast Georgia, in the Savannah area, with 240 people with serious mental illnesses. As part of the study, we actually had access to their rap sheets. So 240 patients in this particular study, and I'm going to walk you through what they get arrested for. This was previously published. We're happy to share any articles with you. So this is a ranked list of the most common charges among people with serious mental illnesses in this group. Out of 240 patients with SMI, 71% had been previously arrested. Their average age was about 35, 36 or so. 71% had been previously arrested, and these are their most common charges. You see criminal trespass, willful obstruction, disorderly conduct, shoplifting, probation violation are the top 5. And then what we then did is we looked at the earliest 2 arrests and the most recent 2 arrests among the patients with SMI who had had at least 4 arrests in their lifetime. And we see that the rank list changes. The earliest 2 arrests occurring at about the age 20 to 21, we see things like DUI, et cetera. But the more recent 2 arrests, we see a different ranked list. Amy, if you'll go to the next slide. So we see things like disorderly conduct becoming much more common as patients are older, if you will, in the course of their illness. We also see other types of charges on the next slide start to really top the rank list. Probation violation is the most common charge among the recent charges among people with SMI. Disorderly conduct is number 2. And then we see charges related to their interaction with the officer, willful obstruction, giving a false name, et cetera. So these are some of the most common charges among people with SMI, and you see that there are very, very few felonies on any of these lists. Probation violation, again, failure to appear to court being very, very common. We then did a study in New York State where we looked at all the arrests occurring in the state between the years 2010 and 2013. This, again, is published, and we're happy to share these articles with you. So what we did is among all the arrests between 2010 and 2013, we were able to flag those arrests that appeared to have occurred in people with SMI by virtue of their Medicaid billing codes. And so there were more than 2 million arrests in the state among people without SMI and 91,000 among people with SMI. And we did the same thing. We basically looked at UCR codes, and these are the most common charges. We see that simple assault occurs in 14.9% of people without SMI, 14.0% of people with SMI, but we see some changes in these patterns between the 2 groups. We see that simple assault is less common, but aggravated assault as a charge is more common among people with SMI. We also see differences in terms of the types of substances that they might be charged for. For example, we see that marijuana possession is less common, but other substance possession is more common. And the next slide. This is a rank list in the two groups. And we see that, you know, shoplifting is the most common charge among the two groups. But we see that among people without SMI, some of the most common charges are DUI-related charges, which we don't see a lot among people with SMI. They tend not to be out there driving. But we see criminal trespass, once again, makes its way onto the rank list, if you will, of the most common charges. So let's move to the next slide. And I'm just going to summarize that across these two studies, we found that people with SMI are charged mostly for minor misdemeanors. Their charge patterns tend to change over time as the course of their illness changes. And these shown here are some of the most common charges, with criminal trespass really topping the charts in many cases. Other charges include disorderly conduct, willful obstruction, etc. So through a National Science Foundation funded study, we really took a deep dive into those specific misdemeanors among people with SMI in 4 cities, in Atlanta, Chicago, Philadelphia, and in New York City. And we studied the processing and use of these misdemeanor charges among patients with SMI. We ended up collecting so much data that we had to put it into a book. This book is called Entangled, and I would encourage you to take a look at it if you're interested in some of the specific charges like shoplifting, criminal trespass, and you know, willful obstruction, among others described in the book. Our goal here really is to drill down and understand why it is that our patients with SMI get entangled in the criminal justice system for these low-level charges, and therefore some policy solutions and program solutions to help our patients not be in a vulnerable situation where they are at risk for a low-level charge. At this point, I'm going to turn it over to Amy, and she's going to talk more about some of those solutions.
So hi, everyone. I'm going to talk a little bit, kind of couch this in the framework of the sequential intercept model, which is a framework for really identifying opportunities for deflection and diversion. And so the sequential intercept model, the original version of it started at intercept 1 with 911 calls and police contact, and then kind of goes through the different stages of criminal legal system involvement that someone with a serious mental illness may have. A few years ago, they added intercept 0 with the idea that having a robust crisis system and a strong community mental health system would allow people to reach out to services and get care when they're in crisis without the need for contact with 911 or law enforcement. I'm going to talk primarily about intercept 1 and intercept 0, but we'll touch a little bit on some of the later intercepts as we go forward. So I'm going to start with intercept 1, which is really kind of that first point of contact someone might have that could result in them getting kind of sucked further and entangled in the criminal legal system. At intercept 1, we have your emergency communication centers, or 911. We have law enforcement, and now we're starting to see the emergence of some civilian response teams as well. So we'll talk about each of these. So one effort to deflect people that are experiencing crisis away from the criminal legal system is the idea of 911, 988 interoperability. So working with 911 call centers to identify calls that don't need law enforcement or EMS response, but that could be transferred over to the 988 crisis line to either be resolved on the phone or where possible, if an in-person response is needed, dispatch of a mobile crisis team. And there's a lot of variation across the country in terms of states doing work to develop 911, 988 interoperability. There's 2 states, Illinois and Virginia, that have legislation that require interoperability. I'm most familiar with what's happening in Illinois. I'm doing some work there. And at this point, they've piloted in a couple of communities some procedures for transferring from 911 to 988. But they don't have full implementation yet. But what we've seen in these efforts to do this is that there is some resistance to transfer calls from 911 to 988. 911 call centers are typically, they're used to having to get calls, someone sent out to a call very quickly. They're hesitant to send something to an external source to resolve it. Certainly, oftentimes they're not aware of the full capability of 988 call centers. And of course, that capability does vary from call center to call center and state to state. There's also concerns about liability that call takers may have of what happens if I don't send police or EMS and something bad happens. And there's a lot of work looking at ways of addressing that as well. So many states are working on this interoperability, but it certainly is a work in progress in most states that are doing it. Also at Intercept One is law enforcement. And probably the most well-known strategy to improve how law enforcement respond to mental health crisis calls is the CIT model. And certainly most people are probably familiar with the CIT as a training model, but it really has other elements, and really at its foundation are partnerships between first responder agencies, community providers, advocates, family members, and people with lived experience. Another element is also identifying a single point of entry for emergency psychiatric care. And of course, when CIT was first developed in Memphis in 1988, it was an emergency department that was worked with the police department to develop memorandums of understanding so that police could bring people needing emergency assessment and get back out on patrol. Of course, over time, emergency departments weren't that thrilled with more people in psychiatric crisis being dropped off. Also, there's a lot of recognition that emergency rooms aren't necessarily the best place to provide support and care for people experiencing crisis. So we're really seeing the development of crisis stabilization centers, psych emergency departments, and various forms of specialized crisis drop-off centers, where police may bring somebody or people may access those without the involvement of police. So what do we know about CIT? There is a growing, actually a pretty solid body of research on CIT. Michael and I have been doing research for the past couple of decades with different CIT programs, and there's a number of other research that have been doing really good work in this area as well. And collectively, across studies, we have really strong evidence that CIT training will improve officers' knowledge about mental illness, their attitudes about responding to mental health related calls, their self-efficacy or their confidence that they are able to respond to these calls, as well as their use of force preferences. We also have good evidence that CIT training and program implementation can increase linkages to care. It can increase transports to crisis stabilization facilities, as well as some linkages to community-based services. The evidence related to use of force and arrest is less clear. These are lower frequency events, so you need a much larger study to get, if there is an effect, to find statistical significance. There are some studies that have found reductions in use of force and arrest, and other studies that haven't found an effect. So it's still a bit unclear. There is evidence that the availability of mental health resources matters, with kind of an interaction effect with CIT in communities with more resources, actually that boosts that effect, where it makes sense. CIT officers that want to connect people to care will be better able to do that if there is more in terms of resources to connect people to. There's also some indication in that training of call takers and dispatchers can be important components of CIT programs. So identifying those mental health related calls and providing that information to officers can have an impact on how things play out. To date, there hasn't been a randomized controlled trial of CIT completed, and that really is the gold standard for determining if an intervention is effective. But Michael and I right now are running a randomized controlled trial at 7 sites where we're randomizing officers to complete CIT training or to hold off on completing CIT training. And we're examining the impact then on their ability to demonstrate CIT-related skills. So we hope to have data collection completed by the end of this year, and then it'll take some time for us to code and analyze that data. So we'll be getting results out hopefully within the next couple of years to really answer some questions that haven't been answered about CIT. We're also seeing at Intercept One mental health law enforcement co-response teams gaining in popularity, and these pair a clinician with an officer to provide response. There's a lot of variation in how these teams operate. In some, the clinician and the officer ride together in a patrol or unmarked police car. Other communities, they may, when a call comes in, arrives and meet at the scene to respond. And in still other places, the officer arrives in person, the clinician provides support via the telephone or an iPad. They vary also in terms of when they respond. Some teams respond directly as first response to hot calls. They're dispatched directly. In other communities, they are secondary response or follow-up after an initial patrol officer goes out to the scene and identifies it as appropriate for co-response. Often these teams are not operating 24/7, and anecdotally, we've talked to communities that have found some difficulty in hiring and retaining the clinicians for overnight and weekend shifts. So there is a body of research on co-responder teams. There's been a couple of systematic reviews, a lot of descriptive research. What findings suggest that these are generally acceptable to stakeholders and may improve that collaboration between police and mental health providers. Across a number of studies, there's also some evidence that they may reduce emergency department transports, but increase admission rate for those transported. So basically having a clinician on scene to make that assessment results in fewer people going to the ED, but it's more likely that those are folks that actually do need to go to the hospital. Whereas if you just have officers on scene, they may not feel equipped to make that assessment, so they will transport the person to the ED for that assessment. We also, looking at service users and family members, some qualitative research has found that these types of teams are preferable over police-only teams. There is one randomized controlled trial of a co-responder program in Indianapolis. That study did not find that the co-response teams were more effective than traditional police-only response in terms of arrests, emergency department visits, or outpatient encounters. So while there is certainly some evidence that these teams have some benefits, the most rigorous study that's been done did not find that effect for the co-responder teams. And finally, at Intercept One, the most recent innovation that we're seeing is civilian responder teams. And on the slide, there's a number of teams that are listed. It's not exhaustive, and this map isn't necessarily exhaustive either, but it does show that many communities are starting to develop civilian responder teams, which are typically teams that are 911 dispatched, They don't involve a law enforcement officer. They may involve a kind of a mix of perhaps clinicians, EMTs, peers. It depends on the program. Probably the most well-known is the CAHOOTS program that started in Eugene, Oregon. They are a partnership between the Whitebird Clinic, a community mental health agency, and the Eugene Police Department. And their teams are two-person teams, a crisis worker and a medic, which is either a nurse or an EMT. They are integrated and dispatched through Eugene's 911 emergency communication system. All the services that they provide are consent-based, so they will go out and work to engage people. But if they're unable to engage the person, they will leave. If they see someone, I actually asked them this too, if there's someone that they're responding to that really is at imminent risk, they will actually call another provider if they're not able to engage the person, but then they'll stay with that person if the person would like them to throughout whatever process is going to happen. Data that the Eugene Police Department has posted indicates in 2021, they responded to over 18,000 calls and very rarely having to request police backup. And oftentimes that because it may be someone that needs to be transported or if there's a safety issue, but they haven't reported any serious injuries of their teams, suggesting that this actually can be done safely. Also, the Eugene Police Department estimates that they divert 5 to 8% of their calls for service that would have otherwise had a police response, but the CAHOOTS teams are managing those calls. And I know the CAHOOTS program has moved around a little bit since 2021, and I believe that there's going to be some changes there, but this is really one of the first kind of examples that got a lot of attention of teams that have shown that it is possible to triage and safely send non-police responses to a number of calls. Another example, a more recent example, is the Denver Star team, which launched with a pilot in 2020. Their teams are similarly comprised of a mental health worker and a paramedic or EMT, and they really go to those low-risk calls, and oftentimes situations that result in people with mental illnesses and co-occurring substance use disorders getting sucked into the criminal legal system when police are sent. So they go to trespass calls, welfare checks, intoxicated parties, and mental health crisis. In their first year, they responded to almost 1,400 calls with no arrest, injuries, or calls for police backup. Again, another example that this can be done safely. They have expanded beyond the pilot. There's one peer-reviewed article on this team, probably the only thing that's out there on the community responder programs. But they looked at 6 months before the pilot and 6 months during the pilot, and they found a 34% decrease in reports of misdemeanor crimes, which suggests if you can send it someone other than police, you may be able to define the situation differently and provide perhaps a response that solves the issue in a different way. So thinking about all these different options for response, our team did a study where we looked at patient and family member preferences for crisis response. It was part of a larger study where we recruited folks. This is a larger study that my colleague Michael Compton led, and Leah Pope led this piece of the study. But what we did is we recruited 50 participants with serious mental illness and a history of criminal legal or arrest for misdemeanor charges that were involved in the larger study. So we recruited 50 patients and then 18 of their family members in order to do some interviewing of them to ask them about their preferences for crisis response. And so really we asked them about what started out by asking them what are their needs when they are in a crisis, and people really talked about some of those concrete needs of someone they can call, access to medication and a safety plan, having a calm environment, but having supports that they can reach out to. And often people talked about informal supports that they like to utilize when they're experiencing crisis, but also the need for empathy and compassion for people when they are experiencing a crisis. We provided them with this visual of different types of crisis response models so that we could then ask them what they thought about these different models and what their preferences were. The first one was a telephone linkage model, which was part of the larger study where basically people could opt into a database. So if they had a police encounter and their name was run, a message would come back saying a mental health concern and a number that the officer could call to get guidance from a clinician in how to resolve the call. Second was a specialized police model, which was really a CIT trained officers responding. The third was a non-police response, which was your civilian responder model. So teams that didn't involve a police officer, but may include social workers, EMTs, and peers to respond. And then ride-along model was your typical co-responder model with an officer and a clinician. So looking at client preferences, there were some, certainly, if you look at the orange bar at the top, the specialized police response or the police-only response option was their least preferred response. And their most preferred response, the blue line, was the non-police response model, although there were people that had preferences kind of around the other models as well. There were some gender differences, with men being more likely to choose the specialized police response as their least preferred response, and women were a little bit more likely to choose the non-police response as their least preferred options. So while there was some variation, it kind of gathered around, preferring less police involvement for the most part. Family member support person preferences showed some similar patterns, with the specialized police response model being the least preferred and the non-police response model being the most preferred. So looking at the themes, when we asked them about their thoughts about these different models, they did talk about really sort of having trained professional response closer to in-person as being preferable. Really wanting to have folks that had some type of mental health training available here. And so there's some different quotes here, and for time, I'm not going to read all of them. But they really wanted some specialized training if officers responding, co-responder, or having a non-police response with someone with mental health expertise responding. Another theme that emerged was having negative associations with police. They really talked about how having police there could increase the stress for the person in crisis. It could be triggering. And it could be really difficult, even if it's specialized and specially trained officers. One person said even though they're trained, it's still just the police. Additional themes kind of came out around safety. So there was some acknowledgement that sometimes it could be useful to have law enforcement there when there were safety issues in terms of protecting a co-responding clinician, or just recognizing that situations where there's a crisis and a weapon's involved, safety may require that police are there. There was also, when talking about the non-police response, there was some talk about how some people don't like having clinicians there because that's associated with someone who's coming to assess them to perhaps for an involuntary procedure. So thinking about those responses and kind of what preferences are, we're also seeing some reforms at Intercept Zero, as well as there's efforts to really build robust crisis response systems. So I'm going to talk a little bit about that. SAMHSA for the past few years has really put a lot of resources into developing some resources for states to develop crisis response systems. And their model really has three components: someone to call, which 988 and crisis lines, someone to respond, mobile crisis teams, and then some place to go, which would be crisis receiving facilities. So some place other than the emergency department or the police station or police lockup. And really thinking about these crisis receiving facilities and supporting the development of crisis stabilization facilities, as well as living room models where people can access support when they're in crisis. There's been federal support, and I'm aware that all of this is sort of in question right now, but over the past few years, there has been increasing federal support for building crisis systems. The 988 legislation gave states the option to create a surcharge on cell phone bills to support 988 call centers, as well as other crisis services. The American Rescue Plan included some enhanced Medicaid match for new mobile crisis teams. 14 states are taking advantage of that. Bipartisan Safer Communities Act also created some new funding via the Mental Health Block Grant Program, as well as the Certified Community Behavioral Health Clinics program, which is requiring CCBHCs to ensure access to 24/7 mobile crisis and crisis stabilization facilities. So I think it's also important to note, as we're wrapping up time, I want to make sure we have time for questions. So there's these Intercept 1 interventions, and now we've seen over the past few years a lot of work at Intercept 0 to make sure that there are options for people besides 911 and law enforcement response. But I do want to note before I close is just that there's some important other intercepts where we do want to think about opportunities to divert people and deflect them from the criminal legal system. The first one I think Michael referenced earlier is just the issue of failure to appear warrants for people who may miss their court dates. I was a probation officer on a mental health specialty team, in the 1990s, and I saw this very often. I had clients that did not have reliable transportation, sometimes had trouble keeping track of days, that had 8:30 court dates at a courthouse that had no public transportation going to it. They missed a lot of court dates, and oftentimes their next interaction with an officer, where the officer learned about the warrant, resulted in additional charges as well, such as obstructing an officer, battery to a police officer. And it kind of created this ongoing cycle for my clients where it was very difficult to get themselves out of the system. So looking at interventions there to one, help people make their court dates. Certainly clinicians and the mental health system has a role in helping clients successfully navigate their court involvement, but also perhaps looking at some additional court policies to reduce the negative consequences when people do miss their court dates. Another point that I think is really important for thinking about supporting people is at that re-entry point. When people are leaving jail and prison, they're very vulnerable. They may have lost their housing, their benefits, and some connections to their social support network. So really putting into place interventions to reconnect them to all those resources quickly so they don't end up kind of cycling back through. And then the final one is around probation and parole violations. We know that people with serious mental illness are more likely to have their community supervision revoked, often for technical violations. So really looking at how we can put some things into place and interventions into place so that people don't end up just getting stuck because their case never ends because of these probation and parole violations. So I think I kept my time correctly. We do have a little bit of time for questions. So if anybody has questions, be happy to answer.
Any questions from the council of the panelists? I see Councilmember Brazil.
About a couple questions. The first on CIT and the training, were you able to identify where in the tenure of the officers the best point to give that training? Earlier in their career, mid-career, kind of where to structure that?
I'll let Michael take this one because I know he had a study that looked a little bit at that.
Yes, we have a little bit of evidence that more seasoned officers do better with regard to self-report CIT-related measures. For example, we did a study of knowledge retention after CIT training, and it appeared that more seasoned officers, in other words, more years of service, did a better job at retaining knowledge about CIT-related things. In the current ongoing randomized controlled trial, we will be looking at years of service with the idea to test that in a much more formal way. Outside of the evidence, though, just in general, we tend to think that more seasoned officers are better equipped, if you will, in a better state of mind, if you will, to benefit from CIT training as opposed to brand new recruits who are going through the academy and learning everything else about their work as a law enforcement officer. And so in general, we believe, and we're hoping to get more evidence for this, that more seasoned officers do better. I would also say that one of the core elements of CIT, among the 10 core elements of CIT, is that officers should self-select into the program. They should want to become a CIT responding officer as part of the model. And that would argue potentially against just training all officers, especially against training officers as part of the academy.
Great, thank you. And a second question, and it's regarding the Cahoots and STAR. I like those, by the way. That's amazing stuff. Was that a stand? So you've got the traditional law enforcement response, you got the traditional EMS/fire response. Was this a third response category, or was this done within the fire EMS silo, so to speak?
For Cahoots and STAR, I think they were, I mean, people talk about the fourth branch of first response. And I think Cahoots was actually funded by the police department, but as a separate response. And I believe STAR's moved around a little bit, but it's really the kind of talked about as a completely separate option from police or EMS and fire.
Do you see that as the ideal model, is moving it out from all of those and have its own separate function?
I actually, I mean, personally, I do think basically having another branch of first response, I think it makes the most sense. It also might help support these programs as being sustainable, is really recognized as this is an important, I would say it's also an ADA issue, of really providing an appropriate response instead of just defaulting to these other responses that are really designed for behavioral health crisis.
No, thank you. I agree with you. So thank you for that.
Thank you, Councilmember. We have a hand up with Councilmember Burt.
Yes, thank you. Very informative presentation. I have 4 questions. One of them is the CIT training 40 hours or 8 hours? Is it the 40-hour training that you were talking about with the study?
Yes. CIT training, at least according to the model, is 40 hours. I know that there are places that are doing something that's less than 40 hours and calling it CIT, but the studies that we've done have looked at the 40-hour training and programs with the 40 hours.
Great. And then have you done any research about online versus in-person training for officers?
We haven't done any research for that. I think there are some kind of components of CIT of this idea of really kind of building that. I think it's important, the environment of the training and sort of the sequencing, and that in-person piece is very helpful to kind of forming and socializing a CIT officer. And particularly, there's some components that I think aren't a significant portion really is that role playing. So I haven't looked at I don't know that there's been any research really looking at moving some of CIT training online versus having it all in person. But I think there is some good justifications for having a good part of it being in person so they can practice those skills.
Thank you. I also wanted to clarify when you were talking about the individual and family response, you used the term crisis response, and I should say this is not my area of expertise anyway, shape or form. So crisis response, I was thinking versus committing a crime. So were you talking about somebody who was suicidal or melting down? How did you define like a crisis response?
So I think we were talking about when someone was experiencing a mental health crisis.
Okay.
Certainly, people could be experiencing a crisis, and there could be aspects of the situation that someone might define as a crime. But and Michael, correct me if I'm wrong, but it was specifically about if you're experiencing a mental health crisis. What is the response you would like?
Yes. Yes.
Thank you.
And I would also add that, yes, we're talking about mental health crisis, but when law enforcement officers are the default responders, one of their tools always will be the possibility of an arrest. And so that's another reason why we need to shift the responsibility of crisis response away from law enforcement. Not to mention the fact that it's just the right thing to do, and it's fair for people with mental health crisis to receive a medical type response, just like someone with chest pain does.
Yeah. I agree 100%. I just wanted to clarify.
Yeah.
And then the last question, and I don't know if this kind of falls outside of what you're studying, but one of the things we see locally is that cycle of 5150, right? That individuals go to an emergency center, gets released, and then weeks later sometimes, we're just cycling over and over and over. And I don't know if that falls into your framework at all, that it's not even the hospital. I guess it's the medical needs not being met.
Yes, it's an indicator that there's some break in the continuum of care for that person, such that they're not able to successfully stay in the community without the in and out of, emergency departments. And so it indicates a failure somehow of the mental health system or social services system to help that person maintain stability, pursue recovery, in the community, rather than being in this cycle that you described. And that cycle commonly involves not just the hospital, but also jails and homelessness. So, those are sort of three parts of a cycle that's way too common among people with SMI.
Yeah.
And I do think we're starting some of these models, and I know many of the mobile crisis team that exist are working to do more follow-up with people. Oftentimes using certified peers to do some engagement and follow-up. And something that I've heard in research with police officers is that something that they really feel is missing. So even when they're going out, a lot of frustration that the mental health system isn't right there to follow up and provide support for people, so they end up seeing them again. So I think we do see some of these newer models emerging that are trying to incorporate that. I don't know that they always have the resources to do it adequately.
Agreed. Thank you so much.
Any other questions of council?
have one quick question. Good morning. Thank you for the presentation. I think a lot of really valuable information. When you talked about the Denver STAR program, you shared that they saw a 34% decrease in misdemeanor crime, which is an incredible number. I'm just curious, did you look at all at what caused that decrease? Was it that police were not responding, so people were less likely to be charged with something like resisting arrest? Or was it that when a different team responded, people were connected with more resources and maybe got help that they needed, so they were less likely to, see crimes like trespassing or drug offenses or that type of thing? Did you look at all at where that decrease happened, or maybe it's a mix of both?
So some of it is methodological. And so the study was done by Dean Pine. I think a lot of people that look at the article say that it represents a 34% decrease in actual crime. What they looked at is reports of misdemeanor crime. And the way those reports happen is if a police officer responds and classifies it as such. So if police aren't going, that's not happening. So it's a little misleading when you look at the article if you don't read it carefully. But what it suggests is if you don't send police, some of these situations aren't defined as crimes. More research is needed to see if sending somebody else actually then provides an intervention that reduces the likelihood of subsequent contacts and reports. But so there's some big limitations there. But basically what it suggests, if you don't send police, these things aren't defined as crimes and counted that way.
Thank you.
Thank you. Any other questions of council, of the panelists? Seeing none, I have a couple just real quick ones. When we talk about this vicious cycle of being involved in some kind of crisis and then no capacity for the individuals, I mean, some of the counties that I've been associated with, they just don't have the capacity for crisis beds for people to land. Hence, you mentioned the 72-hour 5150, and then a lot of the individuals, from my understanding, end up in the county jail or at some other kind of facilities similar to that. And I think there has to be a parallel path that creates this capacity with the projected need. And I mean, we can go and do all this crisis intervention training we have, but unless we have a place for this person to land, it just doesn't. I mean, it's just going to continue crisis intervention mode. And so I think that's one of the things that has to occur. The other is, we talk about the individuals with either mental health or IDD in crisis. We also have to think about the individuals that are responding, their safety. The crisis intervention team or the police officer. I mean, those are factors that have to be weighed in as far as how well we're able to interact, but also not jeopardize safety. And so that's something that I just wanted to bring. Did you guys have any kind of premise or thoughts about how the safety component on that?
So we have a project where we interviewed people working in civilian response and mobile crisis, and also people who utilize crisis services and their family members. And we asked a lot about safety. And so one of the things I think we see is we need to make sure we prepare whoever's responding to manage safety and make good assessments. So if it's not a police response, making sure that we train the folks that are going to maintain safety, but also to assess when they need to disengage and ask for support. And I don't know that in many places that's done. at least for mobile crisis teams. I think there's kind of the default to saying we'll just bring police with because we're not fully trained to, in social work school. I'm at a college of social work. I've been at one for over 20 years. We do not train social workers how to do this and maintain safety in the community. It would have to be extra training. But so thinking that through, I think that's important, making sure that whoever's going is well prepared. I think there's also, and we're seeing a lot of examples of this across the country, is the development of triage protocols. So putting protocols in place at 911 or whoever is picking up the phone to ask those questions about safety. And what we see with, particularly when it's these non-law enforcement teams, whether it's mobile crisis or civilian response, gathering information on the way. So if there's more information you can get, and then making sure that they're prepared to, assess the scene safety, situational awareness, making sure they know how to disengage quickly if they have to, if safety is an issue. So I think there's things we can do. And I think we're starting to see more examples of that across the country of communities that are working through these issues and demonstrating that we can do this safely. And one of the things I think about too is, and we don't have good research on this too, is that sometimes I think sending police can make things less safe if it's really triggering for a person in crisis who's really agitated. But sometimes not sending police makes it less safe. So what we're seeing right now is a whole bunch of natural experiments on communities putting together these triage protocols and really trying to work through those issues. But it is possible, I think, to really start working through these issues, particularly if we're adequately preparing the folks that are going to really maintain safety or to make sure that they have an exit.
Thank you for that. Any other questions from the council of our palace? I don't see any hands raised. If I'm missing you, please speak up. Seeing none, Dr. Watson and Dr. Compton, thank you so much for this great opportunity to glean from your knowledge on what you're doing and some recommendations. I hope that we do you proud at the end of our term at this endeavor and make the right recommendations based on what we feel is a great outcome for the people involved. So thank you so much and appreciate your being here. We're going to move into a
Thank
break.
you.
I know we're running a little late with the council, but we're going to come back at 11:10 and we're going to adjourn and then establish a quorum at 11:10. Thank you.
Go ahead.
Oh, sorry. I guess people are lagging off already. I made an error sending you all on break early, but I guess we can have a break again.
When is what's the next meeting? It's scheduled for 11 o'clock. Is that in-house?
My understanding, we had to break at 10:45 to 10:55. We missed it. And so I was just trying to stay on track for our panelists. I'll be back. We're missing a couple members of 2 or 3 members. We'll give a couple seconds to. There we go. Well, let's see. I hope everybody enjoyed their break. We're going to move on to action item number 7 on the agenda of reconvening the meeting and reestablishing a quorum. Madam Parliamentarian, would you please take the roll to establish the quorum?
Yes, thank you. Members of the council, it is now 11:10 and the meeting is reconvened. I will call the roll starting with Chair Frazier.
Present.
Chair Frazier is present. Vice Chair Zuniga.
Present.
Vice Chair Zuniga is present. Member Brazil.
Present.
Member Brazil is present. Member Brown. Member Brown is absent. Member Burt.
Present.
Burt is present. Member Libero.
Present.
Member Libero is present. Member Pettirudin.
Present.
Member Pettirudin is present. Member Tina Reedes.
Present.
Tina Reedes is present. Members of the council, there are 9 members on the advisory council, and the number required for a quorum is 5. The number present is 7. A quorum has been reestablished.
Thank you, Madam Parliamentarian. We have a quorum. We're going to move on to a discussion item number 8, which is the presentation on AB 988, 5-year implementation plan. Our panelists are Dr. Athabui, if I'm butchering that, I apologize, with the Health and Human Services Agency. Doctor, the floor is all yours.
Good morning. Thank you so much for having me. My name is Antu. Last name is Bui. I'm a community psychiatrist, addiction medicine specialist working at the California Health and Human Services Agency. I've been the project director for the 988 Crisis Care Continuum, working on the 5-year implementation plan for AB 988, which was submitted to the state legislature in January of 2025. I've been asked to provide an overview on the development of the implementation plan for AB 988. It will also provide a bit of a glimpse, point in time of what we have in terms of crisis response in California, and share some data that we have from our populations of focus who needed for those who are at high risk of crisis response, which include individuals with mental health conditions, as well as intellectual and developmental disabilities, and those that are needing tailored responses for crisis that will result in more therapeutic response, and hopefully can reserve about 10 minutes for question and answers. Just as a quick backup, what is 988? You all probably are now well aware of it. It was established nationwide in July of 2022, whereby it becomes the 3-digit number to access the National Suicide Prevention and Lifeline, which had been in operation for over 20 years. Not sure if anyone remembers the 1-800 number to call for suicide crisis. It was 1-800-273-TALK. That number is still in operation. But now if you dial 988 from any telecom device, you will be able to access that national network, which consists of over 200 call centers across the country. We have 12 988 centers in California. More details later on that. It is designed for anyone who is needing support for a suicide, mental health, or substance use related crisis, as well as people who are aware of or know someone in crisis. And they will get connected with a trained counselor when they connect with 988. A crisis is really self-defined. So really, you don't have to triage yourself. If you feel like you need help, you can call 988. And the counselors have a whole triage system by which they can either de-escalate ongoing crisis, provide emotional support, or connect the individual to needed resources in the community. This is an immense opportunity for us nationwide to think really beyond a hotline. There is the in-moment de-escalation of crisis, but really the potential here of connecting people to immediate and ongoing care is a tremendous opportunity for us to think about how do we integrate 988 into a care continuum. And that's really the crux of what we've been working on at Cal HHS in the last few years, working with national, state, county, tribal, and community partners to think about this opportunity for integration of 988 into a comprehensive crisis care continuum. All right, so I just want to anchor us in the fact that Cal HHS has been working on a number of strategic priorities and just focusing on the fact that developing a robust and adaptive crisis care continuum is a core part of those set of priorities. Cal HHS oversees 12 departments and 5 offices, all in health and human services in California. So we really want to think about how do we achieve the same goal for everyone in our state? Really, building a healthy, vibrant, inclusive California. So who are the populations that we need to really make sure that we prioritize? Because those are people who are at more risk of crisis or need tailored services in order to have therapeutic responses to their crises. So just want to anchor us in that larger continuum. Next, I want to let you know that building a crisis care continuum is really a part of an overall transformation of behavioral health in California. It's been a tremendous effort. It's one reason why I joined the state. This administration has invested over $10 billion in building out a robust behavioral health continuum of care. Just want to highlight for you, my job today is to focus on crisis response, which right now we're focusing on 988 and mobile crisis, but just know that there are a number of other building blocks so that we can prop up a behavioral health system. I heard earlier there's concerns certainly about where people can go, a safe place to get help. And Behavioral Health Continuum Infrastructure Program, BCHIP, is a big part of that. For the past several years, we've been investing in communities to build out facilities so that we will have more places for people to go and a safe place to get help, as well as connecting people back to outpatient care so that they can, again, get the care that they need on an ongoing basis. So as part of that work a few years ago, as 988 was really getting ready to be implemented, we needed to develop a vision for what is a robust crisis care continuum in California. So I just want to let you know that this is the background, which was published in May of 2023, which provides for us a vision and a roadmap for where we want to go in California to develop crisis services. So I think earlier, so what is this vision? We heard a little bit earlier from Dr. Watson about SAMHSA's vision in terms of a safe, a place, someone to, so if you're in a behavioral health crisis, that there's someone to call, so someone to contact. So that's really kind of what we are talking about, 911, 988, or any really other 3-digit numbers to call. Our vision in California is that there really should not be a wrong number to call. Ideally, they're 3 digits, so that's what you remember. But wherever you call, there ought to be connection to the right resource that you need. The second part of the crisis response is someone to respond. So really building out mobile crisis so that there's alternative to law enforcement response and therapeutic response to individuals who need it. And then the stabilizing crisis portion, again, I think I mentioned our effort in building out more crisis receiving facilities as well as other services. And then I want to highlight the opportunity for thinking about preventing crisis. So again, it's outside of the scope of my presentation, but Cal HHS has been supporting this administration in building out more preventive interventions, whether that include connecting people to outpatient care or providing other upstream interventions so that, again, people don't need to be in crisis to access care. But if they are in crisis and they do call 911 or 988, we are able to connect them so that we can prevent future crises, preventing both the trauma of future crisis as well as the high cost of providing care during crisis. All right, so how do we do that? The Crisis Care Continuum Plan outlined several what we envision to be essential crisis services that everyone in California ought to be able to access. Some of these crisis services are already present. So what you see in peach color here are some of the services that happen that are currently available. Whether they're available in the right amount is likely not yet, but we have them available and working on scaling them up. The blue is again in the next couple of years. Hopefully, we will have them statewide, and that includes mobile crisis services. And then the gray, as you see, are more kind of user-friendly, more ideal kind of services that are more welcoming. So, but we only have some of them in the state. So certainly more like models of peer respite, as well as in-home crisis stabilization. So this is the span of what we hope to build over the next decade in California. Okay, so let's get down to AB 988. So AB 98 legislation was passed in September of 2022. Only 10 states in the nation have passed legislation with 98 surcharge. This is a tremendous opportunity for us in California. So since January of 2023, all of us who live in California who have a telecom access line has been paying 8 cents per line per month in order to establish this 988 State Suicide and Behavioral Health Crisis Services Fund. Just for comparison, we also pay into a 911 surcharge fee. That 911 surcharge fee is about 30 cents, has been 30 cents per line for several years. Just this year, the 911 fee went up to 41 cents per line. It is capped at 80 cents per line. For 988, we've been paying 8 cents per line for calendar years 23, 24, and 25. It can go up to a cap of 30 cents per line for 988. What does 988 do in addition? It requires the Office of Emergency Services to convene a state 988 technical advisory board in order to advise on recommendations for technical and operational standards and interoperability between 988, 911, and other emergency and behavioral health crisis lines. AB 98 also requires CalHHS to create a policy advisory group, which has met over the past year and provided advice on a set of recommendations for the 5-year implementation plan that we submitted to the state legislature a little bit late, but early January of 2025. It also requires us to post regular updates, at least annually, until the end of the decade on the progress of implementation of 988. All right, so we had about a year to accomplish this task. How did we do it? This is just a map of the project structure of what we did. So at the very top is the goal driving toward the set of recommendations for the 5-year implementation plan. There's a crisis policy advisory group which convened every other month. So they work very closely with other advisory boards as well as state departments and entities. They created 7 work groups. And then we also, the project team did a number of interview surveys, focus groups. So I think the next slide gives you more detail into this effort. So over the course of a year, we convened 7 public meetings of the policy advisory group, which consisted of 43 members. There were 140 members in 7 work groups, which met 21 times over the course of last year. We conducted 13 focus groups with people with lived experience who had experience of the crisis system, and they provided a lot of valuable information on how we can improve our crisis care system. And we conducted over 85 interviews with subject matter experts and other community members. All this information is available in a supplemental document that we submitted called the Community Engagement Report. I just want to give you a sense of the state agencies that have been involved in forming the plan and will be involved in implementing the plan. So these are the state entities. So I mentioned the Office of Emergency Services and the Health and Human Services Agency. We've got the Public Health Department, which will look at public messaging to increase awareness and trust in the crisis care continuum, as well as looking at population data about how interventions can reduce suicide and overdose rates in the state. We've got the Department of Healthcare Services, which is our Medi-Cal authority, and they oversee staffing of 9/8 centers as well as the Medicaid mobile crisis teams. There's the Department of Managed Healthcare, which really work on parity, and so that to ensure that crisis services are reimbursed by commercial health insurance plans. So it's not just reimbursed by the public mental health system. And then we've got the Emergency Medical Services Authority, which will work on making sure that there is good coordination and triage, and the quality of medical care is equivalent in the 9/8 system as in 911. And they also work on the community paramedicine as well as triage to alternate destination programs. So lots of work going on among the state agencies. So I just want to point you to where you can access the plan. We submitted this, so there are 3 documents that were submitted. So we've got the 5-year implementation plan, and I wrote out where the year starts. The first year will hopefully start July 1st, 2025, pending available authority and resources, which we're undergoing right now in the state budget process. The plan is 140 pages, so it's a lot to read, but I will outline for you how we structured it so that it can give you some information that's helpful. The other materials that were submitted, besides the community engagement report, which I mentioned, is also a chart book, which provides a snapshot in time of where the state is in terms of the crisis care continuum. So there's needs and gaps of where we're at, and then the services that are available, as well as things that we're trying to build up. So hopefully that will be a good resource for the community moving forward. All right, let me get to the organizing framework of the 5-year implementation plan itself. So AB 98 required us to address 14 requirements. So there were lots of things to address, ranging from coordination with SAMHSA and the National 988 Network to really connecting and integrating 988 to the rest of the healthcare continuum. So how do we do it? So I just want to anchor you to really at the top is the vision of what we want to build, which is really an equitable, accessible, high quality behavioral health crisis system for all Californians. We divided it up into 4 pillars. So there's really answering 4 basic questions. So the basic questions toward the bottom really is we want to make sure that if you are in crisis in California, will you know who to call? And I think this is why 988 is such an amazing opportunity. When I was a community psychiatrist still working clinically, I've taken a break for the past 2 years to work on this. But I used to hand out like pages of, hotlines and warm lines and a variety of resources to the individuals. Because, when you're in crisis, it's really hard to remember these phone numbers. And I think for us, the idea is, well, gosh, if all you can remember is 988, because we all know 911, that's a tremendous opportunity. How do we make sure that happens? How do we increase public awareness and trust in 988 so that people will call 988? And next one, so once you call 988, will you be connected appropriately? Is there interoperability between 988 and 911? If you call 911 instead, can you be connected to 988? Those are some key questions. And then the next one is, when you are connected to 988, how does the state ensure that this is a high quality service? Remember that this has been built on a very patchwork network of not very well funded national suicide prevention hotlines in the past. So now we are creating a more standardized, hopefully connected, integrated. It's not yet there, but how do we make sure that they work similarly across the state so that the quality of service is the same wherever you are in California? And then the next one is, once you are connected to 988 and getting the care, will you also get access to immediate and ongoing care? So those are the key questions we tried to answer in the 5-year implementation plan. And then, so there are basically 16 recommendations across these 4 sections. And then there were a total of 65 implementation activities. So there are potential activities that the state entities would need to lead and work with local partners in order to effectuate these recommendations. So I can go in a bit more detail in just a few moments. All right, so what are we trying to achieve overall? I just want to remind us that the idea is we want to build a California crisis system that is consistent in terms of access statewide, as well as high quality, as well as connecting people to the right care at the right time, and serving the needs of all Californians regardless of locality or payer source. There are some guiding principles that our policy advisory group came up with, which echoed, again, the idea of what I just mentioned. So we need to create timely and therapeutic access to quality crisis care and reduce unnecessary law enforcement involvement where possible, so that we are prioritizing community-based support, least restrictive intervention possible, so that we can prevent further crises and trauma for individuals seeking help. All right, let me go into some details about what this looks like in our recommendations and implementation activities. So the next several slides show you some examples of what's in the implementation plan. So for each recommendation, so this is in the section of really connectivity and interoperability. So the recommendation is that we are to, at a statewide level, promote coordination and communications across state technology implementation partners so that we can align technology, policy, and practice. The potential implementation activities are outlined in the table below. I apologize for the small print. I put in bold some good examples of what we are actually actively working on right now, so that you can see how we laid this out. So the potential implementation activity, let's look at B2B. So the activity is review and support, as needed, revision and update of the draft transfer criteria between 911 and 988. This is currently being developed by the Technical Advisory Board at the Office of Emergency Services. The state lead, as you can see listed, would be the Office of Emergency Services, as well as Health and Human Services Agency. This is really a very new collaboration between the two state entities. And then these are some of the implementation partners, not exhaustive, but certainly some of the implementation partners that are needed and are willing to work with us on these things. And then this activity will obviously last over the 5 years and probably ongoing, because this is, again, an ongoing effort. So as we develop these draft transfer criteria, we also need to think about how do we do a stepwise implementation to transfer between 911 and 988. The reason why is that we are building a new system over 988. It is not yet at the same level of the 911 service, right, which has been going on for decades now. There are 450 public safety answering points in California, and California receives 27 million 911 calls per year. About, we think, maybe 5 to 15%, depending on the locality of 911 call, may be behavioral health related. So that's a large number. If we were thinking about diverting 911 behavioral health related calls over to the 988 system, we really need to think about it in a stepwise process. So this is kind of what this is outlining. There are now emerging national guidance, for example, from the NENA, the National Emergency Number Association, about how to say transfer suicide-related contacts from 911 to 988, as well as other evidence-based tools that are coming out. So we are trying to think about how to do this in a thoughtful manner to provide guidance so that 911 centers can work with 988 centers and really get people to the right care at the right time. Happy to answer more questions about this later, but this is a work in progress right now. All right, some of the other examples that I can provide. So an example to let you know is that 988 centers, having been National Suicide Prevention Lifeline for over 20 years plus, are really expert at suicide crisis. To get them to answer all behavioral health crises, which is really a very broad umbrella of situations, we really need to train up, think about behavioral health crises that are inclusive of mental health and substance use challenges, as well as families calling in for resources, third-party callers, things like that. So how do we think about expanding the scope of service for 988 centers and supporting them to increase capacity to address this broader scope of behavioral health crisis? So that is an activity that I have bolded here in this set of section. And I think I mentioned integration of 988. So the immediate integration that we really need to work on is a 988 to community-based response. So most of the time, the data from 988 response is that the intervention provides 95% resolution within the contact itself. That's quite fantastic. But in the 2 to 4% of the time, that 988 may need to refer to mobile crisis so that there is a in-person response to the individual crisis in the community. How do we make sure that that works out well? What is the right coordination? As well as in the times that 988 need to transfer to 911 because of a public safety issue, as well as any other number of other types of things that need to happen. And I'll give you some data about that in a little bit. Okay, let me just skip through, because these again are just examples of implementation activities, and I just want to make sure I get to the data to share. So one of the things that as we get into actualizing the recommendations, we need to think about where the state has a role in providing guidance, and it's really in the intersection between systems that there can be people falling through the gaps, as well as confusion about how to connect the dots, right? Because what we've got is a patchwork of components of the crisis system. They are not yet integrated and seamless. So in this diagram, we're outlining the base emergency services. Well, we understand, everyone I think knows the sequence of the event, right? Calling 911 for an emergency. Usually you get first responders. In terms of medical emergencies, you've got an ambulance taking you to emergency department and the hospital. What we're building in the middle are crisis care services, where we've got warm lines or county access crisis lines going to 988. How does 911 and 988 interconnect? How do we hand off to mobile crisis team and other community-based models? And then how do we make sure that people get transferred to the place to get help? So those are the intervention points, the diamonds where I put in some bolded arrows, where our state agencies are working actively to make sure that we provide guidance and support in order to make sure that there's connection between these different components of the crisis system. So just to give you some context of where we are at in California. So I mentioned that we have 12 988 crisis centers. There are now over 1,100 staff who are paid thanks to the 988 surcharge fee. In the past, there used to be more majority volunteers. Now we have more majority paid staff, which is fantastic. Volunteers still are a great source of energy and quality for the 988 centers, because volunteers bring with them a really, strong motivation and mission-driven type of sense. So I do want to stress the fact that volunteers are a valuable part of the community. But the fact that we can pay people, and we really need to ramp up the ability for 988 centers to answer more contacts. So during the first year of 988 implementation, they answered close to 400,000 contacts. That number continues to rise every single month over time. California answers the highest volume of 988 contacts in the country because we're the most populous. 1 out of 10 988 contacts originates from the state of California, and we'll continue to ramp that up all the time. Do want to point out that the mobile crisis response team, so from the state perspective, we know that we have supported over 450 mobile crisis teams in the state. And we have now established the Medi-Cal Mobile Crisis Benefit in 49 counties, serving 99% of Medi-Cal members. This has only been happening since January of 2024, so we still have quite a ways to go. And then on the statewide level, we are building a state-based platform so that there will be full interoperability in the future between 911 and 988. So still quite a bit of work to go, but that's where we are at now. So I think just in terms of emphasizing where 988 is, just want to emphasize again, I've listed for you here the list of 12 988 centers in California. The headquarters is the city where they're at. It is not the service area that they cover. They range very widely. Some of them cover only a single county, and some cover multiple counties. So again, do we have all the 988 centers that we need to connect to local resources? Likely not, but we don't know yet how we're going to think through as a state where we need more centers, and how do we determine the baseline statewide minimum standards by which we're going to train, support, and staff these centers so that we can meet the needs. So this is, again, ongoing work. Just going to share you a little bit of data so that we can think about the connection between 988 and 911. So let's break this down. This is data from the first year of 988 implementation in California. I think, as I mentioned before, typically about 95% of 988 contacts are resolved within the contact itself. So of the 5% or so that get referred outside of 988, where do they get referred to? So there's a category, something called emergency rescue. So that is either a situation in which the 988 counselor determines that there is imminent risk to the individual because of suicide risk or any other kind of medical emergencies, or a public safety issue. It is unclear. So there's an emergency rescue category. There is a transfer to 911 category, which is very, very few, but I think that's generally a public safety issue. And then there's the category of referral to mobile crisis team, which for this year was 2.85%, which is quite in range with the 2 to 4% nationwide referral rate from 988 to mobile crisis. So let's take a closer look at what emergency rescues entail. So this is from a different period of study. So this is now the second year of 988 implementation in California, and this is only for 6 months. So this is data that we got from the Department of Healthcare Services. So if we looked at the number of contacts that resulted in emergency rescue, So the very far right bar, this is now 1.5% of the total call. But in breaking down, what we looked at is when there is a need for emergency intervention from the 988 counselor's perspective, using their triaging protocols. Typically then, the majority of emergency rescue tend to involve law enforcement engagement. So for us, that's a place for us to think about really training, support, thinking about how to develop MOUs, triage protocols, warm handoffs between 988 and 911 to ensure that these emergency rescues result in the most therapeutic care possible for the individual needing help. Alrighty, let me share with you a little bit about what we did for some of our populations of focus. I don't need to quote all the data to you, but I just want to point out to you that in the chart book, which provides the assessment of the system of care in terms of gaps and needs and available services, we do know that there's a huge opportunity for training in terms of individuals being stopped by officers who were perceived to have one or more disabilities. So I don't think I want to go over this too much because we're running out of time, but I want to just point out to you what are the resources that we have on the 988 site right now. I'm not saying that this is adequate or not adequate because we haven't had a chance as a state nor the authority to overview, but this is what's available from the national 988 network, which is overseen by SAMHSA. So on the right-hand side, these are the training resources that are available now to our 988 centers. So the links that you see there would give you access to resources for 988 centers in terms of working with people with neurodivergence, as well as other disabilities such as deaf, hard of hearing, or hearing loss. The very bottom here, I just provide you some links with what our Medi-Cal mobile crisis teams get trainings on in terms of crisis response strategies for adult individuals with intellectual or developmental disabilities, as well as crisis response strategies for children, youth, and families for individuals with IDD. On the left-hand side is just some, again, very sparse, but we have a video phone system on the 988 system. And then I just want to outline for the state of California, there is a family urgent response system. This is for foster children, but some of those kids may have IDDs or mental health conditions. So those are some of the current support that we have. One of the things that we do need to do more of starting year one is, again, assessing whether these training standards are enough or do we need to build more to meet the needs of Californians. And then I think I'm just going to get to our last slide of here's some links and resources, email contact. And I think that's it. I'm just going to pause for questions here.
Thank you, Doctor. Any of the council have questions for our panelists?
I've got a question. Thank you for the presentation. With the 12 different agencies that do have the 988 centers, do they all report to one database for you to obtain that information? Because are some nonprofits or some city or government, like what does that system look like so that we may be able to, call this a best practice and then advocate for additional entities that have the ability to do what the 988 call centers do?
Yeah, thank you for that question. Currently, they are required to report certain measures to the 988 National Network Administrator run by SAMHSA. And then the states have some federal grants so that we have some requirements to report certain data back to SAMHSA. We have not yet developed a set of statewide measures for California. And that is certainly one of the things, sorry, I skipped over that part, but on the data metrics, right? The question is, now that we are really actually with the 9.8 surcharge fee, taking on the responsibility of sustainably funding these 9.8 centers, what are the statewide measures that we need to collect as a state in order to ensure quality services? That is in development right now.
Okay, thank you. Thank you for that.
Any other members of the council have questions of our panelist? Councilmember Burt.
Thank you, Dr. Bowie. That was very informative. As a member of the autism community, there was a lot of confusion around the terms behavioral health and mental health, and whether the 988 number would be for families that have a son or daughter that is dysregulated and maybe becoming aggressive in their home. I was curious. At first, it looked like it was going to cover it, and then it looks like it doesn't cover it. It's for individuals that are having a mental health crisis. Can you clarify that?
Yeah, thank you for that. The reason why it's confusing is because there is what 988 centers do now well, and then there is the future aspirational vision of what they can do given this opportunity, right? So I think what they do well is definitely covering suicide crisis, because that's what they've been doing for over 20 plus years. Behavioral crisis is a very broad category, and we are really working on how do we empower and support them to achieve that level of quality service, right? And that includes probably a lot more training to serve particular populations, as you mentioned, in terms of families and individuals with autism. Like, I think if we poll the 9.8 centers right now, maybe some of them would feel that they have adequate training, but others, smaller centers, may not be. So again, we need to understand where they are at in terms of how are they going to get to that standard to be able to respond to these particular crises for these particular populations who will need tailored services. That's a thing that we would like them to get to in the future, but we need to identify and evaluate where they're at and what else we need to do to support them to get there.
Thank you. Another question. I was under the impression that it was anonymous. And is that not the case? Because I heard you talk about the Medi-Cal billing and being able to bill other insurers. One of the issues, again, our autism community has is a lot of fear, right, around calling in, will adult protective services or child family services be called because their child is dysregulated? Is it anonymous? Is it optional? How does that work?
Yes, 988 is a free and confidential service. You do not have to provide any identifying information in order to receive the service. I believe the phone number is visible, and I believe the geo routing, which occurs now for 80% of mobile phone numbers, will connect you to the closest 9.8 center to you physically, but that is the only identifying information. So you do not have to reveal any data. All demographic data are voluntary, and I think actually probably most of the time we do not have any data demographically.
Thank you so much.
Any other members of the council? I'm not seeing any. Dr. Bowie, thank you so much for your presentation. We're in hope of you are able to accomplish your goal of integrating the population, IDD population also, and working towards a kind of a parallel path for mental health and IDD behavioral issues. And with that, thank you so much, and we're going to move on to our next panelist. And this is number 9, discussion item, presentation by Vinny Ng. He's a nonprofit director, advocate, and brother of Jasmine Ng. Vinny, are you available? I mean, if you are, you have the floor.
Good morning, everyone. My name is Vinny Yang, and I apologize. It might be a little loud over here for just a moment. It's both sunny and raining here in San Francisco. So, but I want to just thank the council for this time. Thank you, Chair Frazier, Vice Chair Suniga, and all the other council members. I also want to thank Kelly Burns and Lisa Ehrlich from the Department of Justice for encouraging me to speak today with you to provide the perspective of a family member who has lost a loved one to police violence. I appreciate this opportunity to support your work in building public safety systems that truly serve all Californians. I don't have a deck presentation, so I will just be sharing my words today. Again, my name is Vinny Yang. I'm the American-born son of Cambodian refugees who arrived to California in 1979. I was raised in Los Angeles. I now reside in San Francisco, where I serve as the interim executive director of Open House, an aging services nonprofit dedicating to empowering older adults to overcome their unique challenges with affordable housing, services, and community programs. Today, however, I speak in my personal capacity. As a resident of California, a proud Angelino, and in honor of my sister, Jasmine Ha Ng, who was killed by LA County sheriffs in 2012 at a community mental health clinic. Against this conversation today, I also just want to note that on Friday, the Federal Department of Health and Human Services announced that the Substance Abuse and Mental Health Services Administration, SAMHSA, and the Administration of Community Living, ACL, which supports aging and disability populations, will effectively cease to exist. Without federal coordination of these particular agencies, I've already heard that caregivers are fearing for devastating disruptions to services that contribute to independent living for individuals with disabilities, older adults, and those seeking to improve care for behavioral health challenges. Back to the matter at hand. The creation of this advisory body reflects many decades of advocacies, not just by myself, but other individuals with disabilities and surviving family members who also have lost loved ones to police violence. Many Californians are placed in crisis situations daily due to unmet care needs, leading to emergency responses that too often end in harm. Families continue to fear that calling 911 or other hotlines may result in unwanted outcomes that lead to coercive approaches, unnecessary interactions with law enforcement, incarceration, physical harm, or death. Now, you're probably wondering why I'm speaking to you today, and I'm hoping that by sharing my personal path to advocacy, you can understand that a lot of the work that you're exploring through this council is long overdue, and that many people have invested a lot of time and energy into trying to shape and transform systems that actually care and respond in a meaningful way. My advocacy began in 2012 after my sister was killed while experiencing a mental health crisis at a clinic where she had been a known patient for over a decade. That day, she did not have an appointment. She was simply waiting in the lobby to speak with her clinician. She was 4'9", weighed less than 100 pounds, and carried a backpack into the lobby. Distressed but nonviolent, a staff director, following protocols of the clinic, called non-emergency dispatch line and explicitly informed the dispatcher that while she was not a threat, that they were requesting backup support. Within 10 minutes of that call, 4 deputies arrived. 2 were dispatched and 2 self-deployed for the purposes of training. 1, a field training sergeant, and the other, his partner, barely 1 week into their role as a deputy. Within 15 seconds of visual contact, all 4 officers applied force, leading to a tragic and fatal outcome. Sorry. My apologies. I haven't told that story in a few months. Imagine how someone in distress would react to 4 armed officers drawing weapons and shouting orders. I think about her last moments almost every day. What could have been different, and what kind of world can we build where my sister Jasmine would still be alive? Since then, I've participated in a number of advocacy efforts to change the systems that harmed her and so many others, advocating for policies that prioritize care, de-escalation, and community-based crisis response. Through a civil lawsuit and later thanks to implementation of former Senator Nancy Skinner's Senate Bill 1421, I obtained records and reports from internal reviews that found the use of force in my sister's situation to be excessive and out of policy. But this process also exposed systemic failures in transparency for all stakeholders and timely accountability. We can't be afraid to precisely describe how systemic responses fall short and to change operations in a timely way so that practices that lead to bad outcomes are interrupted and law enforcement personnel are trained to community standards. In addition to that work, I also fought for fair access to the California Victim Compensation Fund, a state-run last resort financial resource for families impacted by violence. At this time, that fund is limited and not used by individuals recovering from police violence. Personally, I was fortunate to access mental health services at great personal financial cost. I left a stable job to recover. I withdrew my retirement savings and used credit cards to pay my bills. Most families do not have this option. The California Victims Compensation Fund continues to be inaccessible to most individuals that experience police violence because access to that expense reimbursement resource requires a police report. Many of you know that when individuals are involved in incidences where a law enforcement agency and/or an officer applies force, it is harder to obtain a police report for this very purpose. Beyond these advocacy efforts, I've been part of an informal support network of families affected by police violence throughout California. Over the last decade, I've been in touch with sisters, brothers, mothers, aunts. Every single family I've supported shares the same belief that they wish that the violence had never happened in the first place. In 2013, I set out to ensure my personal story could drive changes in law enforcement response. I was fortunate enough to be connected to the president of the police commission here in San Francisco and was appointed to the San Francisco Working Group to advance changes to the mental health crisis response by SFPD. From 2013 to 2016, I served on the San Francisco Mental Health Working Group, where we successfully revamped the Crisis Intervention Team Training Program based on the Memphis CIT model at the time, and overhauled SFPD's use of force policies, which were adopted in 2016. Those sweeping changes were later used to inform Assembly Bill 392, the California Act to Save Lives, championed by now Secretary of State Shirley Weber, which codified the principle of sanctity of life in defining when necessary use of force is allowed in law enforcement agencies across California. In addition, in Los Angeles, I continue to work with family-led coalitions advocating for law enforcement accountability of the LA Sheriff's Department and LAPD. Most recently, I've worked on implementing Assembly Bill 118, the Crises Act, funding alternative crisis response models statewide. Authored by former State Senator Sidney Kamlager, who also sponsored SB 882, which established this advisory body, the legislation has invested $9.5 million in community-led crisis response programs overseen by the California Department of Social Services. They are now rolling out pilots in 4 Northern California regions over the next 3 years. A separate non-governmental agency is finalizing standards for collecting data to measure the impact of these community-based programs, to support long-term policy change, and to disseminate best practices from those pilot programs. I want to share a couple of guidances for the Advisory Council as you continue to finalize your report and establish follow-up for the recommendations you will be making. As you engage with impacted families and disabled individuals who survive police violence, I urge you to remember the following things. Every person who comes before you is seeking to undo systemic harm. Many have endured indignities, a lack of access to meaningful health care, and exposure to violence instead of care. They often are asked to speak publicly about their trauma, which requires immense courage. And so when they share their experiences, they are reliving their pain just to justify their place in this conversation. Families continue to face immense barriers in learning the full truth about the violence that their loved ones are exposed to. In fact, many law enforcement agencies continue to routinely withhold critical details in incidences involving law enforcement. I encourage you to seek multiple perspectives of critical incidences and validate various sources of what may have happened, and not to rely on official reports or investigations from agencies. Additionally, a lot of the individuals that you'll encounter in this work may not fit traditional definitions of family. Caregiving networks extend beyond biological relatives. Believe survivors when they tell you who should be included in discovering how and why individuals are persisting despite the systems that they are in. I also want to encourage this body to understand the role of reducing stigma and discrimination against people with disabilities, intellectual and developmental disorders. People experiencing crises are not inherently violent, but the expression of a lack of emotional regulations can often cause others to feel uncomfortable and conflate that discomfort with a propensity for violence. Words matter, and when we pathologize a person's disability, behavior, cognitive impairment, and frame them as subjects or perpetrators instead of people needing care, we are solving for the wrong thing. After the reforms were adopted in 2016 in San Francisco, the deadly force incidents dropped significantly. This was something I was extremely proud of. However, I realized that we stopped the bleeding. We weren't addressing the underlying causes. We are still sending vulnerable people into situations that don't meet their care needs. This advisory body must continue to move upstream, examining and reforming dispatch systems statewide to ensure that law enforcement is not the default crisis response. Dispatch protocols vary widely across the state of California. Rural areas often run dispatch under the oversight of law enforcement agencies, while urban and suburban areas have separate emergency management departments that are coordinated by a statewide agency. Why does dispatch matter? Think of dispatches as intake nurses. They assess needs, leverage care plans, and determine appropriate responses beyond police intervention. Without improving dispatch training and protocols, we will continue to funnel vulnerable individuals into avoidable, harmful encounters. When we focus on dispatch and establish a foundation for informed consent at the point of dispatch, we are more likely to match resources with needs and solve the problems that continue to surface in our communities. The rise of older adult homelessness, as well as the ongoing challenges faced by California's unhoused population, is an important field where your recommendations can be studied, adapted, and improved. As states are increasingly burdened in creating and funding localized care systems that keep people with disabilities living in community, I urge this advisory committee to factor the external conditions at the federal level into your considerations. We must build emergency response systems focused on care. Solutions exist in community, and People with lived experiences are the architects of public safety. We must preserve their ability to live independently in community, connected to their care providers, and promote their agency and independence. Thank you so much for your consideration and the opportunity to share these thoughts with you. I'm happy to answer any questions you might have.
Thank you. Any members of the council that would like to ask any questions or any kind of comments? I don't see any hands. Well, there one, Commissioner or Councilmember Burt.
Thank you. Vinny, I just wanted to say thank you so much for sharing your perspective, and so sorry about the loss of your sister.
Any other comments by the panel? Or by the council to the panelist? Seeing none. Vinny, thank you again. Many thanks for sharing. I know it was hard, but you're doing good work in your advocacy, and keep it up and keep following us and keep recommending and keep helping others. We appreciate your involvement. Things get better when people have, a stake in the game. And so thank you so much for sharing with us.
Yeah, I just, thank you, Chair Frazier, and thank you, council members. I just want to reiterate, I started this advocacy work in 2012. It's 13 years later, and I'm continuing to have very similar conversations, and progress is slow. And I want to encourage you that despite the uncertainty that a lot of these programs that have long been funded by the federal government, that we have to make these investments. Over 200 Californians die because of police violence every year. And those numbers continue to remain pretty immovable if you look at the data. And there are those of us who advocate for these reforms and these changes that wonder if we're just getting better at counting or if things are getting worse. So it's truly important, the work that you're doing, and I appreciate the efforts that you are contributing to this.
Thank you. With that, just one last ask of our council to see if there's any questions or comments. With Vinny? Seeing none. Again, thank you, Vinny. Do good work. Thank you. We're going to move on to our lunch. So we are scheduled to be back at 1:30. And so we will break for lunch and adjourn, and then we'll reestablish a quorum at that time. Thank you, everybody. See you then.
The mission of the Bazelon Center for Mental Health Law is to protect and advance the civil rights of adults and children with mental health and developmental disabilities. We do this through research, policy advocacy, community engagement, and litigation. And central to our first 50 years as an organization has been combating unnecessary institutionalization and advancing community integration for people with disabilities, including connecting people with mental health disabilities with voluntary supportive services in their own homes and communities. I want to pause before going too far in case I'm using a term that's unfamiliar. I personally use the term mental health disability where others might use terms such as mental health condition or mental illness. The reason for that is not because the terminology that I use is better or correct. It's because when I started my legal career, I discovered that individuals with what I call mental health disabilities, things like anxiety, bipolar disorder, depression, PTSD, folks didn't know that they were covered by disability rights laws, such as the Americans with Disabilities Act and Section 504 of the Rehabilitation Act. So that's the reason for that terminology. Next slide, please. So today I really appreciate the opportunity to speak with you all. Oh, and I realized I have control over the slides, so I will do that moving forward. Thank you. Today I'll be speaking with you all about the importance of dispatching mental health responses to mental health calls wherever possible. I will provide examples of mental health response programs and evidence of their effectiveness in communities around the country. And then I'll also share findings regarding harms that are associated with unnecessary police response to mental health emergencies. So first, just to set the table for us here, mental health emergencies and physical health emergencies are both health emergencies. When we think about how we treat physical health crises, generally, when someone's experiencing a physical health crisis, they, when the system is working, receive a prompt and often life-saving emergency medical care from health professionals like paramedics or EMTs. And the appropriateness of sending a health response to a physical health emergency is obvious. If, God forbid, I had a loved one who was having a heart attack and I called 911, I would expect medical professionals to respond. I might also expect that the person on the other end of my 911 call is trained to talk me and my family through anything that we can or should do while we wait for those first responders. And finally, when the responders arrive, I would expect them to concentrate on my loved one's health and helping them get better. I would not expect my loved one to be treated as a threat. I would not expect them to be handcuffed or placed in the back of a police car, especially without receiving medical attention. So a person experiencing a mental health crisis should similarly receive a health response from a crisis system that is designed to serve them. This includes hotlines that have trained mental health clinicians and people with lived experience, mental health crisis responders to assist on the scene, and if necessary, peer respite centers or staffed crisis apartments for them to go. I know that we're after lunch, and I promise that I won't spend too much time on the legal part, but I just want to do a little bit of level setting. I won't get too in the weeds, just introduce some principles, and then if helpful, I'm happy to chat more once the group has had some time to digest, because I know that this is a lot of dense information. So I mentioned at the top that folks with mental health disabilities are protected from discrimination by federal laws, including the Americans with Disabilities Act and Section 504 of the Rehabilitation Act. So here, and I know someone might be on the phone, so I'll read briefly from the slide. The Americans with Disabilities Act and the Rehabilitation Act prohibit jurisdictions from excluding people with disabilities from participation in or denying them the benefits of public services, programs, or activities, or otherwise subjecting them to discrimination. So what does that mean? In this context, the program would be a jurisdiction's emergency response program, and the benefit would be an effective and timely emergency response. Therefore, sending police to respond to 911 calls for mental health emergencies while sending medical personnel to other medical emergencies in many situations is straightforward discrimination against people with mental health disabilities. And the reason for that is because doing so would mean that someone with a mental health disability, by reason of that disability, is getting a less effective emergency response to their healthcare needs. Another example, it would be discrimination if a hospital emergency room referred anyone who's receiving chest pain to its security guards while providing a health response to anyone who's not receiving chest pain. These laws also include affirmative obligations to ensure what's called an equal opportunity to benefit from emergency response services and to provide what are called reasonable modifications or accommodations. This means that when a jurisdiction provides an emergency response program, it must ensure that it's doing so in a way that provides everyone an equal opportunity to obtain the same result, i.e., a timely and effective emergency response. It also means that a jurisdiction must make reasonable modifications or an exception to a general rule when it's necessary in order to avoid discrimination on the basis of disability. We're almost done. Again, I'll keep this high level, but I just want to flag for your attention some work that's been done at the United States Department of Justice, which I'll add a verbal asterisk. There's a lot that's in flux right now at the national level, Currently, all of these findings continue to stand. I did my best to ensure that all of the resources I'm providing today are still available. And I'll let you know if there have been any changes. But in the past about 2 years, the United States Department of Justice has issued findings in multiple jurisdictions and has filed a statement of interest in litigation in Washington, D.C. at this intersection that we're talking about in terms of responses to calls involving behavioral health emergencies and whether or not it's appropriate for police to respond to those calls. To pull specifically from a local-ish example, in the case of Phoenix, Arizona, I'll read briefly from the findings that the city and the police department were found to violate the ADA by discriminating against people with behavioral health disabilities when providing emergency response services. The ADA prohibits cities from excluding people with disabilities from participating in or denying the benefits of cities' services, programs, or activities, or subjecting them to discrimination. To avoid discrimination, Phoenix must provide people with disabilities an equal opportunity to participate in or benefit from city services. When providing a service to people with disabilities, the city must also ensure that it is as effective in affording equal opportunity to obtain the same result as that provided others. Phoenix's public services and programs include its emergency response and law enforcement systems. That means that Phoenix's 911 call center, as well as officer encounters, are subject to the ADA. All of these are letters of findings, and so the slides link to very long reports that were put out by the Justice Department, as I mentioned, over the past couple of years. The earliest of those, and this is part of that asterisk, is currently being examined by a court in Kentucky. So that's with respect to the findings in Louisville, Kentucky from March of 2023. This past December, the United States Justice Department and the Louisville Metro government jointly entered into a consent decree that requires, among other things, a non-police response to people experiencing mental health crises where a police response is not warranted. The parties jointly sought court approval of that consent decree, and since that time, there's been some opposition from the police union and some other groups based on reasons related to other portions of the agreement. As I'm sure you can imagine, the agreement is quite comprehensive. The latest there is that the court held a hearing in January and asked the parties to provide more information, and the parties have been doing so over the past couple of months. So that's one to keep an eye on as we might get more information there. So moving on from the legal and from the federal government for the time being. In addition to the legal framework, experts do recommend across the board sending trained mental health professional to respond to mental health calls because they found it to be both safer and more effective. The most recent resource linked on this slide is from SAMHSA in January 2025, and I'll just leave that potential asterisk unnoted, but this guidance still stands as of today. But in January, SAMHSA issued updated guidance on behavioral health crisis care. That guidance sets out overarching behavioral health crisis systems, and those principles include that behavioral health crisis systems should be person-centered, family-focused, provide the right level of care at the right time, prioritize quality and effectiveness, be trauma-informed, and developmentally appropriate. In those guidelines, SAMHSA also recommends that communities have mobile crisis services available that do not involve law enforcement, recognizing the potential harm and stigma associated with police involvement in behavioral health crises. When communities meet these goals and send mental health crisis responders to mental health calls, they have found it to reduce hospitalization and lengths of stay, to reduce frequency and intensity of future crises, to reduce involvement with the criminal justice system, and to promote continued participation in community services. This next point is so important, I gave it its own slide. Systems that provide mental health responses to mental health calls also see significant cost savings. In particular, a 2022 Stanford study found that the cost of dispatching mental health workers in Denver, Colorado was much less than the cost of dispatching police. Specifically, that study found that the cost of dispatching STAR teams in Denver was 1/4 the cost of dispatching police. Or to quote the report, quote, in other words, the direct costs of having police as the first responders to individuals in mental health and substance abuse crises are over 4 times as large as those associated with a community response model. You may have heard of the CAHOOTS model in Oregon. CAHOOTS has been estimated to save the city of Eugene, Oregon, over $20 million per year. And additional studies have found that peer crisis services in particular are far less costly than inpatient and emergency department crisis services. That updated SAMHSA guidance that I just mentioned cites several studies in particular. One of them compared the cost of a mental health crisis program, of a mobile crisis program, with the cost of a regular law enforcement intervention, and found that mobile crisis services resulted in a 23% lower average cost per case. Another found that mobile crisis services can reduce the costs associated with inpatient hospitalization by approximately 79% in a 6-month follow-up period after a crisis episode. And finally, a study specifically focused on youth compared youth who utilized mobile crisis services to those who did not. And it found that youth who received mobile crisis services had a significantly lower likelihood of a subsequent behavioral health emergency department visit, which of course, in addition to the cost savings, is a fantastic result because anyone who's been through an emergency room knows how stressful that can be. So I'll share a bit now about some additional research findings on what makes for an effective crisis response system. And then I'll share examples from across the country of how communities are responding. First, what makes for an effective crisis response system? I could spend a lot of time on this one, but I'll focus just on a couple and then feel free to let me know if we want to come back and dig in more closely. First, timeliness. Mental health response has to be timely, as or more timely than a police response would be, and should actually help resolve the situation. Nobody's going to call if they don't think that whoever they're calling isn't going to come fast enough. They need to be available 24/7, again, as available as other first responders. They need to be voluntary, meaning helping people learn about their options and helping them choose the services that work for them. This can be hard to do, I want to acknowledge. It can be hard to do in the moment, but when we look longitudinally, when we look over time, connecting folks with voluntary supportive services that work for their needs, which may not align with what the service provider thinks that their needs are or should be, that's what's really going to make the difference. That's what's going to reduce folks cycling in and out of these systems over time, is connecting folks with the kinds of services that are actually going to work for them. I'll skip down to leadership of people with lived experience. So folks might be more familiar with how peers can provide life-changing support in other contexts, such as support groups for veterans, for people who have cancer, for people who are grieving, or for individuals who are struggling with addiction. Peers can and do all the time provide life-changing support in the mental health context as well. Similar to those other contexts, someone who's been there and lived it is just going to be able to connect in a way that somebody else cannot. And evidence has found that across the board, peer-led and peer-involved crisis supports have been just more effective at supporting individuals through de-escalation of a crisis, engagement with services voluntarily, stabilization long-term, and avoiding crises in the future. Every community should strive to have the capacity to provide these services. Additionally, skipping to the end, thinking about post-crisis prep, engaging individuals in thinking about what services and supports may help them reach their goals and meet their needs and then effectively linking them to those services and supports is one of the most important things that a crisis responder can do. Because again, the goal is not just to solve this crisis, it's to prevent crises from taking place again in the future. And in terms of positive outcomes, the proof is in the pudding. Whether an individual has a positive outcome after receiving crisis services is essential to assessing whether that service has been effective. I'm going to go quickly across these next couple of slides because I think the better use of our time is to get to the examples. But I'll just briefly note that the federal government in the past has referred to the need for communities to provide 3 aspects or categories of crisis services: someone to call, somewhere to call, someone to come, and somewhere to go. This suggests that they're all equally important, but we have found that not to be necessarily as true as the general bumper sticker message. And that's because when call centers are effectively staffed, the majority of calls can be resolved over the phone. So not as many calls are going to actually need that in-person response. And then when someone with specialized training, including peers, is able to respond, the vast majority of those interactions get resolved in the field. So once we get to that somewhere to go, we're actually looking at a smaller and smaller piece of that pie. To zoom into an example here, in Houston, Texas, there's a crisis call diversion program, and they place mental health crisis phone counselors within 911 dispatch to provide a 24/7, 365 mental health response to mental health crisis calls. They started this program back in 2015, and it's a citywide collaboration between the City of Houston, the Houston Police Department, Fire Department, Emergency Center, and the Harris Center for Mental Health and Intellectual and Developmental Disabilities. They accept referrals from 911, police, and fire, and they respond to callers of all ages who call in for behavioral health assistance. Call takers at this diversion center conduct mental health risk assessments, provide immediate de-escalation and safety planning, and diversion services by linking callers to ongoing mental health and basic needs resources. To throw some numbers at you, last year in 2024, the Crisis Call Diversion Program processed over 7,500 calls for service to 911. Of those, as I note in the slide, they diverted about 62% away from first responders, including over 3,200 law enforcement diversions and over 1,400 fire EMS diversions. With a team of just 8 crisis phone counselors, 2 supervisors, and an annual budget of approximately $460,000, CCD has resulted in $2.7 million in cost savings for the City of Houston just this past fiscal year. Additionally, recognizing the importance of our public safety officers and everything that we ask of them, calls that have CCD interventions in Houston see a 19% decrease in officer time spent on a scene. So just to briefly bring this point home, before we think about investing in large numbers in psychiatric stabilization beds, we need to be thinking all the way upstream. Because as I said, we all know that there's a mental health crisis. We all know that there's not enough services out there. But if we can take a moment, give ourselves a moment to zoom out, step back, and think about what if we really invested upstream, we might not need as many beds as we might think that we do. So I'm going to skip a little bit just to make sure that we have time to talk about community examples nationwide. Before I zoom in further on any example, I have to again give the disclaimer, no program is perfect. And importantly, each community's needs are different. So my goal here is to share some lessons learned and initial findings from communities that have tried it to further inform this council's recommendations for what might work in California's communities. And no one size fits all is going to work for California because we've got about 16 different countries within our state. So hopefully giving you a wide menu of examples is helpful because we might be able to pull from those in terms of what might work in different counties. So I want to give you an example, a couple of examples here of communities that have piloted and scaled up. So in our research at the Bazelon Center of Communities that send mental health responses to mental health calls, one approach we've learned about is communities that start small. They pilot it with a small program, one van, limited hours, limited days, limited call types, and then they gradually scale up. One example of that is in Albuquerque, New Mexico. Like Cahoots, the community safety department in Albuquerque, they don't make arrests or issue citations, and they connect individuals and families to services in the community. So they went from 5 employees to 130 employees in 2 years. They started with limited hours before they went graveyard. They're now operating 24/7. The Community Safety Department is a cabinet level department that is separate from and independent of the police and fire departments. From its inception in September of 2021 to July of 2022, so that's just a less than 1 year period, they responded to 14,000 situations. And they estimated that of the 14,000 situations to which they responded, approximately half of them would have previously resulted in a police encounter. Since then, as I mentioned, they've begun operating 24/7, and they've expanded their scope and effectiveness. So now from July of 2023 to 24, they responded to over 40,000 calls. That's up from 14,000 in the 21 to 22 period. So that's a 61% increase from the year before. And somebody else did this math, not me, a 347% increase from 2 years prior. Another example of starting small and then scaling up is in Denver, Colorado. So here they started with 4 clinicians in 1 police district. And then after 3 to 4 months, they started, as in their words, spreading like wildfire. Other districts started reaching out to ask when they would get a clinician. And they expanded the call types that they responded to. Because let's, think realistically, we're not talking about this in a vacuum. These are complex issues, and these can be scary situations. And some folks just need to see it to believe it. And that's what they have found in some of these pilot programs, is that folks who were initially hesitant, once they saw it, then they were like, well, now I want that in my community. But it wasn't until they saw it. Harkening back to that 2022 Stanford study that I mentioned a while ago, they found good evidence of the program's success. There was a 34% drop in low-level crime with these community responders, both because the STAR program diverted from arrest and prosecution many who would have been charged with crimes had the police responded, and because STAR was meeting the people's needs, and it had a spillover effect that less low-level offenses were being committed. And in addition, during the period studied, serious crime did not rise. I'll just briefly note an increasing number of jurisdictions, including St. Petersburg, Florida, Durham, North Carolina, and Albany County in New York, among many others, have specifically designed their programs so that unarmed teams are answering 911 calls that would have otherwise defaulted to a police response. And some programs, like in Atlanta, Georgia, and the Cahoots program in Oregon, pair mobile response workers with emergency medical technicians as part of that emergency response. There's also a number of studies that'll have real big long footnotes that note a lot of other examples across the country. So pivoting slightly to acknowledge some of the harms that have been associated with unnecessary police response to mental health emergencies. Police are trained to respond as police officers, not as mental health workers, and they unfortunately do not have the training and expertise that mental health workers do. So dispatching police officers to respond to 911 calls involving people with mental health disabilities does risk serious harm with an individual potentially being unnecessarily arrested, incarcerated, injured, or killed. Police are also less likely than a mental health responder to link an individual to resources that can help address their mental health needs and avoid mental health crises in the future. Encounters with law enforcement can be dangerous and sometimes deadly for people with mental health disabilities, with the risks to Black and Brown people being especially high. And many of these dangerous encounters begin with a call to 911. A lot of these calls are calls for help coming from a family member or a friend. They might be asking for a wellness check or reporting a suicide threat. It might be from a member of the public who's concerned about someone who they don't know, or the call might even be from the person who is experiencing the crisis themselves. But too often these responses end in avoidable tragedy. Guidance from the United States Departments of Justice and Health and Human Services report that people with disabilities may account for 30 to 50% of the incidents of police use of force. And according to SAMHSA, people in need of mental health support are 25 to 50% of the people shot and killed by law enforcement. And as I noted, the risks are even greater for Black and Brown people, with Black Americans being over 3 times as likely as white Americans to be killed by law enforcement. Again, unfortunately, a study has shown that of police encounters that resulted in the death of a person with mental illness, roughly 40% began with a 911 call from a concerned family or friend who was seeking help for their loved one. Even when a 911 call does not end in a use of force, dispatching police could risk serious harm with the individual being unnecessarily arrested and incarcerated. We know that people with mental health disabilities are grossly overrepresented among those in jail. Although people with serious mental illness comprise only 4 to 5% of the United States population, they make up 20% of the jail population. There's over 2 million people with serious mental illness who are booked into jail each year, and jails are now among the largest providers of mental health care in the United States. And I'll put quotes around the provider, because once in jail, people with serious mental illness can be incarcerated for far longer than others, in some facilities twice as long or more, and most don't receive the treatment that they need. And upon release, with public benefits interrupted and now a criminal record, the individual is only more likely to be unemployed, homeless, and rearrested. I'll note here in framing, checking in about co-response models to clarify, the Bazelon Center's position is not that co-response is never warranted, but it is not a substitute for a mobile crisis response. So co-response should only be considered in cases where a police response is actually called for, and a co-response is sent as a reasonable modification to also send a mental health professional because there is a known or suspected mental health disability. It also matters how co-response teams are structured and who leads. So generally, in as many cases as possible, the mental health responder should be in the lead, but of course, this may need to be case by case depending on the circumstances. Otherwise, we would not recommend using a co-response model because of the information we've seen so far. There is little concrete evidence that co-response models can reduce the risks that we talked about. Also, dispatching police can reinforce stigma and inaccurate perceptions. A co-responder model in many cases is premised on the assumption that most behavioral health related calls pose a safety risk. In effect, people with mental health disabilities are treated like criminals because their health emergency involves mental health versus physical health. But this is a flawed premise, and it's not borne out by the communities across the country that have implemented teams that are unarmed. Any police involvement, even if well-intentioned, can be traumatic, particularly when guns are drawn. In many ways, a police response can exacerbate rather than help a situation, unlike a mental health response. Almost done. I recognize that part of this council's charge is to evaluate trainings, including trainings with respect to interactions with people with disabilities. So at present, we don't have a ton of information, but I'll share with you what I do have. A 2016 review and a meta-analysis found that on average, equipping officers with crisis intervention training has not been found to have a significant effect on arrest or use of force outcomes, and has no significant positive impacts on police encounters with people with behavioral health disabilities. A 2022 Temple Law Review article cited to a 2012 study of the Chicago Police Department, and that study actually showed a marginal increase in use of force by CIT trained officers over their non-CIT counterparts. Police are trained to respond as police officers, not as mental health workers, and they do not have the same training and experience that mental health workers do. To bring us back to the example we talked about at the top of someone having a heart attack, would you prefer to have a police officer who's had a 40-hour training in how to respond to someone who's having a heart attack, on top of the million other things that we expect our public safety officers to know and do on a daily basis? Or would you rather have someone whose job it is to respond to health emergencies if it was you or your own loved one? Whereas mental health responders are able to de-escalate, provide that immediate help, help people stay in housing and receive needed care, and to link folks with services that can help address the underlying mental health needs, stop the cycling, and avoid mental health crises in the future. I appreciate that we covered a lot of information, and you've also had a very long day. So please do feel free to reach out if you have any questions or concerns, or you would like more information about what I've covered. Finally, I'll also share the Bazelon Center's website, where you can find a lot of the studies and reports and cases that I mentioned. I do appreciate your time. Thank you so much.
Thank you. Any members of the council have any questions for our panelist?
I do.
There you go. Councilmember Tingarides.
Thank you so much for that presentation. Very informative. I'm wondering, has there been any assessment or findings on the lack of, see, how can I put this? Like, I'm from Los Angeles, and one of our difficulties is, you know, we have a co-response model where we have a mental health clinician that rides with the police officer, but they will not respond to that incident unless they ensure that individual most times is armed with a weapon or a knife, and we're getting dispatched to those. We finally were able to get enough resources to have it, you know, 24/7, but there's difficulty in hiring or getting social workers to want to engage in that type of work. And so I'm just wondering, have there been any studies or an increase in wanting to have LCSWs become part of that profession, so that it doesn't have to be a co-response model and it could just be those individuals? And then the second part to that is, in some of the research that you have done, are those individuals being dispatched when there is a weapon involved, but they're having a mental health crisis?
Those are great questions. No, that completely made sense. Thank you. I'm going to have to go back to my notes for the first one. For the second one, it's an interesting question with respect to the presence of a weapon, because we have been speaking with individuals who live in jurisdictions where everyone has a firearm on their person, like at the grocery store. And so what do they do in those instances? And so what we have found is kind of a web of, it's a very, very individualized determination for each community in terms of what that actual flow chart's not the right word, kind of the decision tree for each individual. I'm going to put in the chat a link to, I believe it's this one, to a brief that my organization recently filed in the Louisville matter that I mentioned earlier. And this includes a declaration by a former chief of police from Utah who speaks to that process. And the kind of short summary answer is that it depends on the jurisdiction, and that this can be a situation where starting small with pilots and then scaling up can be helpful. And so some jurisdictions kind of start with the low-hanging fruit, so to speak, of like, well, wellness checks, or, you know, certainly where there's no weapon present, and then they kind of scale up. Because the presence of a weapon, the mere presence of a weapon, the presence of a weapon that's being directed at the individual themselves, the presence of a weapon that's being directed towards other individuals, those might each get a different kind of response.
Understood.
Thank you for both of your questions. The question with respect to hiring, that's a really tough one. We do not pay these people well enough. We really don't, and we need them in every single community. This is one where it's a little bit of a cop-out to say some of these call centers can help to alleviate some of that burden, because they can be a little bit more remote or national in scope. But difficulty with hiring is really difficult. I've been in conversations about maybe loan forgiveness programs, or are there things kind of realizing the financial barrier to a lot of this work for folks? And are there ways to even get folks into the educational programs that are necessary in order for them to become licensed clinicians without having the barrier? I mean, I'm sitting on loans personally.
Yeah.
Are there ways for us to lower the barrier to enter the profession? And then also, are there things that we can do so that once folks are in the profession, we're able to provide the supports that they need for them to stay? These are hard jobs. So it's really tough. I'm going to go back to some of my notes because I'm thinking of a conference from a year-ish ago where I might have more. So I'm happy to be in touch about that.
Thank you. I agree. My daughter's a grad student at USC getting her LCSW, and I'm going to be very, very, very poor. Thank you for your response. Thank you.
Any other members of the council have any questions of our panelists? Not seeing anything. Monica, thank you so much for participating today. Wealth of knowledge, and again, follow us, and as you see our path, if you feel inclined to engage again, please do. We'd look forward to your engagement.
Thank you very much.
And from the council, we thank you dearly. Thank you. So let's move on to right on schedule. Action item, or excuse me, discussion item number 13. And this is a presentation by May Thornton Mahara, the producer of Being Michelle, Dr. Mel Kennedy, and Delbert Whittier, and Dr. Gabriel Lomas. Are these panelists in the queue, staff?
Yes, and we have one other panelist, Dr. Deb Guthman, who's here with us, and Dr. May Kennedy did not make it, but the rest of us are here. Thank you.
Perfect. Thank you so much for joining us.
Before you begin, May, will I need to turn on the ASL interpreters for your presentation?
Yes.
Allow them to speak?
Yes.
Yes.
Please.
Okay.
Just tell me when we're ready.
Okay, I'm just getting them.
Okay.
Okay.
This is the interpreter. Is there a way to make Dr. Wetter larger? Because I see him as a small.
Are we still in the ASL room?
No, you are now in the grid.
Okay, just wanted to make sure. Okay, so we need to get
I'll do my best, but this is the interpreter. I see Dr. Wetter as a small tile.
Can you pin her, Jesse?
I can try to pin him.
Wait, I only see May. Who am I missing?
Dr. Wetter,
I'm not seeing.
Dilbert Wetter. I'm sorry.
Oh no, I want to get everybody pinned that I need to get pinned. Dilbert is one.
Got it. Okay, I have Dr. Wetter pinned. I'm ready.
Okay, good to go.
Ready? Okay.
Floor is yours.
Okay. So thank you to all of you for having us here today. My name is May Thornton Mera. I'm the producer on the award-winning documentary Being Michelle. Our team of deaf and hearing filmmakers, leaders, and advocates worked 5 years with Michelle Ricks to bring her story to the world. We're most excited at the powerful film and its ability to educate many people, and as a tool for all of us to change things to help make our systems better serve individuals like Michelle. We've brought a short trailer for the film that we'd like to show all of you, and then we'll introduce all of our team members and we'll have a discussion about this project. So if you can play the trailer.
Just one moment.
The longer one first, larger one first.
Yeah, I'm pretty sure. Let me make sure I have the correct one. Give me one moment, please.
Okay. While they're getting that up, I'll just say, I think I could speak for all of our team members. We would have been thrilled to have seen services like the Bazelon Center was just mentioning, mental health responders respond to any number of Michelle's incidents in her lifetime. I do believe that we wouldn't be here on this panel sharing this film with you all.
Okay, I'll go ahead and start it.
Thank you.
She's terrified of police officers.
You want to take your jacket off because you're hot?
Are you hot? She won't talk. She's dead.
Oh, she is.
Uh-oh.
Okay, let me see if I can start it over. Well, it played fine in the test.
Of course it did.
Hold on one moment.
Well, I'll just share a little bit. You know, we by chance met Michelle. My husband and I are social impact documentary filmmakers. And as we just started learning a little bit about her life experience, we knew we wanted to collaborate with her to bring this story to the world. As I mentioned, she grew up in rural Florida, north central Florida. I believe that, you know, education is key. Police need to be educated. Folks within various systems need to be educated. But comparing someone like Michelle finding access to communication in a rural setting as opposed to in a city setting is definitely something that needs to be considered in how folks are trained and how resources are provided. Michelle was born deaf into a hearing family, which is the experience of about 90 to 95% of deaf individuals, unless that family has the knowledge, resources, and understanding of how to help that child connect with language access, then the child experiences language deprivation, and that was very prevalent for Michelle in most of her life. So as she, ended up in these various situations in life, having the ability to communicate with police or with the systems was very difficult. One of our partner organizations is the Greater Los Angeles Agency on Deafness, and Patricia Hughes, the executive director, wanted to be here today, wasn't able to, but she did want me to share just that for her team and for GLAAD, when they do connect with someone like Michelle, they ensure language access for her. In our film, you do not see that happening for Michelle at any point along the way. And for someone like Michelle, what's needed is a certified deaf interpreter. That is a deaf individual who understands sign language as their native language and can better communicate with someone like Michelle and understand what she's understanding or not. One of our main hopes for this film is that people better understand that access to communication is a basic human right, and that is not something that Michelle ever had access to in her interactions with the system.
Okay, let's try this again.
She's terrified of police officers.
You want to take your jacket off because you're hot?
Are you hot? She won't talk. She's dead.
Oh, she is.
I'm going to request maybe that we send everyone the trailer. Also, the trailer is public on our website, www.beingmichelle.com. I'm sorry that technology is failing us today. This happens sometimes. But I'd like to go ahead and introduce our executive producer on the film, Delbert Wetter, to share his perspectives on what changes would better benefit someone like Michelle, who is deaf with an additional disability, who experienced language deprivation, doesn't have access to communication in the way that other folks do, whether they're deaf or hearing or someone with a developmental disability. So thank you, Del, for sharing your perspectives.
Hello, everyone. Thank you. My name is Del. I became involved with this film because it was personal for me. There were several in several levels. I went to law school, and when I graduated law school, I moved to California. And I navigated, it was a journey, and I immersed myself in filmmaking. And I've been involved ever since. It was interesting how the deaf community, how deaf individuals interact with law enforcement, the judicial system, the court system, the jail system. And in the video, it was such an opportunity for me to really dive into that. I knew that I would touch a lot of sensitive issues that we're faced with today, things that we wouldn't even realize until diving into this. My son is autistic, and I, as a father of a child with autism, I've always extra sensitive to situations like these challenges, these misunderstandings, these occurrences that happen in life. And when I see my son being overwhelmed or impacted by situations like this, it's really tough to communicate. Communication is a challenge, period. And it leads to a lot of breakdowns. And people who are deaf, and they're faced with a lot of communication breakdowns. People who themselves are nonverbal, or perhaps people with APD, auditory processing syndrome.
It's
auditory processing syndrome. So ADP are able to process and not able to really, they can hear it, but they not necessarily can't process that. It just doesn't make sense. So there are various types of disabilities that impact effective communication. And in Michelle's case, it was clear that she was deaf plus other disabilities, developmental disabilities. And people can't see beyond her deafness sometimes. And so we tried to link that communication was the key to the other issues that she was experiencing. And the system failed her to meet her basic needs in a variety of levels in life. So her story, in her story, she fell through the gaps because her voice was not met, was not heard, so to speak. So this film highlights these different levels of her challenges that she encountered. So we try to bring in, a highlight to Michelle to be able to have her voice be heard, so to speak, for the first time in her life. So one of the largest lessons we learned in making this film was we realized to give people access not only to the meaning of understanding, but perhaps give a deaf person the language that maybe is considered access to that person. Not necessarily what all deaf people understand, but for her. And so we brought in an interpreter. Like, for example, we bring in an interpreter to read the Miranda rights. And they interpret it, but it's not necessarily going to be understood by the person receiving the information, which is Michelle's case. So they need to take an extra step to make sure that access that is being provided is also attainable by the person who's receiving the information. And so that's an additional mode of support, which we call as a certified deaf interpreter, or CDI. And that role is important for the deaf person to have that support, that accommodation, to make sure that they understand what is being explained to them, whether it's in a legal proceeding or what have you. So it's essential that they understand. So May, I'm going to hand it back to you.
Del, as we were making the film, about halfway in, I came across a book, Deaf People in the Criminal Justice System, and I was so thrilled. And this book was edited by Dr. Deb Guthman and Dr. Gabriel Lomas here, and another couple of editors. It's the first conglomeration of research on this population. Several of the authors of articles are from the UK, so we also understand that Michelle's experience is not just special to the United States. This is a global issue of language not being accessible for deaf individuals. But I want to introduce Dr. Gabriel Lomas to share some of his perspectives.
Hi, everybody. Can you hear me? Great, great. So I'm Gabe Lomas, and just before I get started, I just want to let you know that I have quite a setup here at my house. I have a camera down below, and I have multiple screens up high, so my eyes are not looking at the camera. I apologize about that. So I'm Gabe Lomas. I'm a program director for the Masters of Counseling at Gallaudet University. And I have some deaf people in my family, so I've been signing to some degree since I was a child. When I was younger, I worked as a sign language interpreter. I was also a teacher of the deaf, and I also was a contractor with Child Protective Services in Texas. So in that role, I did over 2,000 forensic evaluations. And lots of those evaluations happened to be with deaf and hard of hearing people. And because I got fluent at doing the evaluations and I could do them in sign language, I began to do expert witness work across the nation in multiple states where attorneys would bring me in to help to get to understand the clients and to get justice. And so I began to notice some of the injustices in that work. And that kind of led me to doing the collaboration with Dr. Guthman and some other colleagues where we wrote that book. And then when I met May and her partners, in the filmmaking, I was just floored at how well aligned the content of the book was with the film. So I'm not sure how much to share here. I don't have like a PowerPoint prepared, but I do have a few notes that I've kind of written down, some things that I think might be helpful to think about. One of the areas, because I have background in school and also in psychology, I wrote a chapter on the school to prison nexus. And so sometimes I think, law enforcement gets a lot of heat for um, um, children getting arrested and incarcerated. But I think, deaf and hard of hearing people have a little bit of a more unique experience. And certainly law enforcement is not the only variable there. To me, I see about 8 different variables, and one of them, the first one I think is critical, is language deprivation. A lot of deaf people, when they're young, when they're born, and they start to grow up, that's our critical language learning period. That's when people begin to develop their language abilities. And when deaf children are born, they don't have access to visual language that they really need. And so as they get older, they are often language delayed. And then if there's complicating factors such as disabilities, cognitive, delay, that further delays their language abilities. And if you think about that, well, as they get older, that delayed language really impairs their ability to communicate around the community. Like, for example, I was involved in a case once where somebody, told a person, not to talk to the younger person because that was it was against the law for a person who was over 18 to be in a relationship with somebody who was younger. That deaf person had no idea what they were talking about, and so the limited language ability is really powerful, I think, in cases like this. And I think that we have done, and our society has done a disservice to deaf kids as they grow up with very limited exposure to sign language. And I mentioned it a minute ago, cognitive factors, additional disabilities are also very problematic, like you saw in the clip with Michelle. And I think some of you guys have seen Michelle, the Being Michelle film. The cognitive factors are a huge problem because it's difficult to navigate your society, your community when you've got cognitive delays. And then when things begin to intensify and you have interactions with the police, when you get in the courtroom and you have interactions with an attorney or with a judge, those communications really, can be very confusing. They're confusing for me, and I'm pretty highly educated. I think also one of the failures that we have too here is schooling, lack of education for the Americans with Disabilities Act. The ADA is the one primary law that protects deaf people, and we do not have a required curriculum to teach that to people with disabilities, nationwide. That really, to me, is a shame. That's a failure of our system. It should be required under IDEA that we teach kids with disabilities their own rights, for when they graduate high school and begin to navigate their communities. You might have also seen, if you saw the full film of Being Michelle, you might have also seen the significant child abuse and neglect that she went through. Kids with disabilities have higher propensity for, being exposed to child abuse. And so you're probably familiar with the term adverse childhood experiences. We see that a lot more frequently with deaf kids being exposed to, households where they have these negative childhood experiences. And for hearing kids, we do have some support mechanisms. Schools are major mandated reporters, and we can get them interventions. But those same interventions are very difficult to get for deaf kids. And then if you think about, well, maybe we can find out, that they have an adverse experience, but then what kind of an intervention are you going to get them? Because there just aren't providers out there who, do you have signing social workers? Do you have signing, counselors and psychologists? Like that pool of providers is very limited. Also, there's a concept out there. It's not really well known, but there's a concept out there in our field called fund of information. That's just how much does a person know. Now, I would argue that you and I have so much information that we intentionally unplug. We are inundated with information every minute of our day. Sometimes when you go to a restaurant, they've got a little monitor, on the table that's giving you, news, and your phone is constantly beeping with news. But the problem is with deaf children really is that the problem is exactly the opposite, that they often lack information, and the information that they get is just, it doesn't always make sense to them. And so sometimes even the information they see might lead them in wrong directions. The last 2 points would be literacy. You know, you guys have probably all read court documents, and the court documents can be pretty overwhelming and confusing. Deaf kids have an average reading level of 4th grade, and that's really not their own fault. It's just that, you know, learning English is really an exercise in phonics. And if you can't hear the phonetical sounds, you're not going to develop the English literacy that you need to become fluent. And so the complexity of court documents is really a challenge for deaf people. And then I guess financially, another key piece is financial reimbursement. Working with deaf people, you know, often requires, you know, additional support services, you know, having interpreters present and having specialized clinicians, you know. So when you think about a deaf person who might be involved in jail, or a deaf person in a psychiatric rehabilitation center, you're going to spend more money on that person. And we need to, but we are, you know, many organizations are reluctant to make that investment because they're trying to seek the profit. And so the reimbursements that we give to organizations for working with people with disabilities really need to have a different formula to help make sure that we have true access for people with disabilities, you know, and deaf and hard of hearing people. I have additional notes, but I think I'm going to pause a second because my wonderful colleague, Dr. Guthman, I want to make sure that she gets, you know, her time as well.
Thanks, Gabe, and Deb, take it away.
Okay, great. Hello, everyone. Thank you so much for including us in part of this really important topic. So I'm glad to be here. Just a little bit about my background, because we all come to things from a little bit different point of view. I've worked in the field actually for, I can't believe it, but over 45 years. And so it's been a long time. I have members of my family who are autistic and have other kinds of special needs. So I always had that interest as well. I started out as a teacher of the deaf. I worked as a counselor with deaf individuals, both in secondary and college settings, and then became an administrator and worked validating instruments in American Sign Language, because that's another issue, as Gabe talked about, English being used. But a number of people that we work with use a visual language, American Sign Language, which has its own set of rules and grammar, and Dell is communicating in that way with the interpreter at this point. And so there's a lot of considerations. I'm a certified sign language interpreter and worked at the California School for the Deaf for a number of years and continue to do work with them. So I think I want to focus on some of that, as well as another big part of my life and why I got involved with this book as well, is I started one of the first inpatient treatment programs for individuals who are deaf with substance use issues. And it's one of the only ones that was functioning in the United States. So a number of the individuals that came into that program had police encounters and also ended up in prison settings and had a wide range of functioning level and often had unequitable treatment throughout the process. Sometimes would actually not be held accountable for their behavior because the police didn't know what to do when they would encounter these individuals. And other times when put in prison, and it still continues, not have access to appropriate communication or programming. At the California School for the Deaf, I was responsible for all clinical services, legal involvement, IEP process, admission process, and I was the police liaison. So at the California School for the Deaf, we had anywhere from 300 to 400 deaf students that lived on campus, a percentage of them. And there's another school for the deaf in Riverside, California that we worked with. So we worked with the California Highway Patrol. In early years, we had different police just that would come if there were issues on campus. In later years, we found it much more amenable to have an officer assigned to the campus for a number of reasons. So a lot of my job was working with the police liaison And when there would be interaction with the police for our students, and we served from birth to 22, we found that there were incidents that would occur often. If someone was just a beat cop coming to campus, they had no idea how to work with a sign language interpreter. They had no idea how to work with contact that occurs when you're dealing with a minor and families. And we had situations where individuals would end up in a prison setting. We would find out after the fact, and they had no communication. They were held in a very unsafe situation. So one of the things that I feel is very, very important is the training piece. And so I think both Del and Gabe have set up kind of some things that I want to just let you know about in terms of training that I think is important, and share a few resources with you before I turn it back over to the rest of the team. First of all, I think it's important for us all to remember that a deaf person, like anyone else, as you're seeing, is a unique individual with their own communication preference. So some individuals may be fluent in American Sign Language. Some may use more of a gesture system because of linguistic issues or other. And some people may prefer to speak for themselves, but need to have interpretation for their receptive. So it isn't like one thing fits all. But when we're talking in this context about a person that we'll call deaf plus, so a person who is deaf with additional needs, we need to really keep in mind that in a training protocol, we need to focus on all of these different scenarios. It's important not to provide training in a silo. It's not a one kind of fit for everybody. So that's the first thing I want to mention. And the thing that I have seen that is most successful is really a scenario-based training. And I'm going to share with you a couple of resources that are out there. And after this is over, I can send you some of the links if you're interested of some other programs in other states that have put together scenario-based videos for law enforcement to use, and really developed a curriculum along the way that is very viable for police officers to use. Because if you think about the whole scenario, any of us are very highly stressed, highly alert. I'm sure I know for me, if I've ever been pulled over, of course you think, what did I do wrong? What's going to happen? And everything is heightened. So imagine if you're a deaf individual who is either walking along the street, in a home if they're not able to drive, or in a scenario where a police shows up. Everything is heightened. And so some of the nonverbals that may be because of the disability can be misinterpreted by that police officer to have some other kind of meaning. If the person makes a loud vocalization, that could be interpreted incorrectly by the police. So the way that we really need to approach this is by providing training. And again, I think scenario-based training is the best way to try and do that. And I could go into detail about some of what I think that should be including, but instead I think I'll talk about in California, we have some great agencies to collaborate with. May mentioned GLAAD. And for those of you that aren't aware, in California, we have 8 different centers that are funded by the Department of Social Services that are called Deaf Access Programs, and they're throughout the state. In the Sacramento area, we have NorCal. Now, as an example, NorCal has reached out to me to be involved with legal expert situations when they're dealing with cases. They have a lot of resources around the area of Northern California where I reside. Down in the Los Angeles area, GLAAD works in that area. We also in California have 21 regional centers. And I was really excited to see that the Inland Regional Center, which is down in the Riverside area where the other school for the deaf is located, actually in December of 2024 had a pilot program going, working with police officers in doing not just sign language, doing deaf awareness. So that again, through scenarios and situations, you learn more about the community, not just how to do ABCs, not just how to say, how are you? We really need to go beyond that, because who's really going to remember and be able to use that? It's important to know how to access resources, what a certified deaf interpreter is. Where do I go for those kinds of things if I'm encountering a deaf individual? But they would be a great resource as well. And I can send you some of the information about the program they're doing. On a national level, one of the states that's done quite a bit of work with the police is Oregon. And they're the ones through a program called Bridges that have videos that are available that show some different situations of mock encounters with police, going into a home and then talking about breaking down how you would deal with this. And they also came up with, and I'm going to show you this if you can see it. Can you see this? I can't see myself, so I don't know if it's showing up or not. So this is again from Oregon, and this is something they give people to keep in their wallet that talks about communication preference, where you can point to the picture. In this case, they use it more for the deaf person to have to show to the police, but there's other states where police officers have these when they encounter a deaf person to help know their preference for communication. So the pictures would be sign language interpreter, writing, and X across lip reading, because there's about 20% or less is visible on the lips in terms of lip reading. So that's not something we really ever want to be depending on for communication. And then for people who do drive, some deaf individuals keep this in their car. So if they are stopped, so that the police officer knows that they actually are a deaf individual. There's other states that, again, for a person who has a state issued ID, not necessarily a driver's license, because a lot of the people we're talking about don't have driver's licenses, but ID, there's a code on it in Illinois that again indicates the person is deaf or hard of hearing. So that helps that if there's a suspicion that, oh, this person is just faking it, but that's not the case. So I am a proponent of training, and I'll be more than happy to share with some of you specific resources. We all bring, again, a lot of background information and have worked with the police in different capacities, but I think it's really important to give people that opportunity. Deaf people deserve equal access in all settings, as Michelle should have had and did not have. So hopefully you'll be able to see the film and continue to think of this population with the work of your committee. Thanks.
Thanks, Deb. I have a note from the team there that the
I'd
trailers
like to,
working.
if
Oh, go ahead.
if I may, this is Dow, I'd like to add something. Just really quick, I wanted to add Deb's comments, about the training programs. They are wonderful programs. And a lot of those programs have deaf people involved, skilled presenters that provide the training. So that's a really important component, that people receive the training who have experience interacting with true, actual deaf people. So that is a key component that I think it's important to see how a deaf person communicates, to see their facial expressions rather. There's sometimes a lot of misunderstandings. They interpret that as being aggression, but it's actually how people communicate. They show their expression through the face. It shows their mood. And there's different ways of speaking. You have voice inflection, voice intonation, and that it really shows the mood of the person, if they're stressed or anxious. So that's the same as facial expressions for a deaf person. So it's important to have a deaf model to show people and include that in the training. So I just wanted to add that part.
Thanks, Del. So I think they're going to show you the trailer that's working now, and then we'll have some closing and see if you all have any questions, and then wrap it up.
She's terrified of police officers.
You want to take your jacket off because you're hot?
Are you hot? And she won't talk. She's dead.
Oh, she is.
Michelle and I met when she came to my Sunday school class at Lowell Prison. She's had a really rough life. I became Michelle's guardian because If I didn't, she was going to be institutionalized. When she came to us, she was on so many medications.
I can't even conceive of not being able to hear and not being able to talk in Florida State Prison.
The biggest hardship is not knowing what causes her to have the flashbacks with the PTSD. Hey, we need your help. Michelle's missing again. There's a deaf girl that might be walking the tracks.
The court say if you run away, you can't go to jail.
There's this thing called due process. Michelle has the right to a fair trial that she understands. If you can't understand what's being said, nothing about those things are fair. We are setting out to prove that to the court.
Michelle?
If I were a prosecutor, I could make a compelling argument why Michelle should go back to prison.
Thank you. So I'd just like to, my closing remark is that you all help to ensure the basic human right to communication for people who are deaf and people who have developmental disabilities in all interactions with police and other systems. So do you all have any questions from any of our team members before maybe Dell and Deb and Gabe want to have one last remark?
This is Dal. I'm open to questions.
I have a quick question. Would it be possible to get a link to that document that you held up with the communication options? Or maybe a copy could get emailed out?
Yes, I'll send it out. It's actually part of, well, I have it separate, but it's also part of a PowerPoint that the group in Oregon uses for the training. So if one of the team tells me where I should send it, I'll send that to you.
Okay, great. Thank you.
Mhm.
Questions from the council of our panelists? Being and hearing none. I want to thank the panel. It's been a long time in coming. Remember the preview in Sacramento? And thank you for doing that in Sacramento. And a lot of valuable information was shared. And it's been a concern of in public comments that we do recognize the deaf and the sight impaired. So thank you for that presentation, and we'll hopefully be able to put it to good use, and you'll be proud of the outcome when we're ready to do our report. So again, thank you for your participation. We're going to move, and I need staff's counsel. We did 17, but were you agenda item 17, were you complete, or did we break off into public comment on that issue? I guess I'm asking if you finished on 17.
Thank you, everyone. Bye-bye.
Oh, yes, thank you. Thank you so much.
Chairman Frazier, this is Vice Chair Zuniga. I've been back on for about the last 10 minutes and just wanted to let everyone know that I'm rejoining and have my adult son in the room with me, but I am off camera for disability related reasons.
Welcome back and thank you very much.
And Chair Fraser, this is Cindy, the ASL interpreter. We just need to make sure we go back into the ASL room.
Let me know when you're prepared.
I guess we're already in, we must already be in the ASL room.
We are in the ASL room. I think just remove us from, unless you want to see us working.
Okay, everything's set?
Everything's okay now.
Okay, great.
Okay, thank you so much. Well, let's go ahead and have a scheduled break from 3:05 to 3:15. We'll reconvene at 3:15 and then hopefully staff will either have the remainder of 17 to go or we'll move on to 18. So see you all at 3:15. Thank you.
You could hear her pretty well. It's the one. Good enough.
It is 3:15. Welcome back. We're going to move on to our action item of reconvening the meeting and reestablishing a quorum. Madam Parliamentarian, would you please call the roll?
Yes, I will. It is 3:15 and I will, as the advisory council meeting is now reconvened, I will call the roll, beginning with Chairman Fraser to reestablish the quorum. Chair Fraser.
Present.
Chair Fraser is present. Vice Chair Zuniga.
Present.
Vice Chair Zuniga is present. Member Brazil.
Present.
Member Brazil is present. Member Brown. Member Brown is absent. Member Burt.
Present.
Member Burt is present. Member Libero.
Present.
Member Libero is present. Member Tingarides. Member Tingarides is absent. And member Petarudo.
Present.
Present. Mr. Chairman. There are 9 members on the advisory committee. Advisory council, and the number required for a quorum is 5. The number present is 6. We have a quorum.
Thank you. With that, we do have a quorum. We'll move forward. I guess my question to staff is, did we complete agenda item 17 when we move forward, or do we need to recapture that?
Yeah, we paused it so we can recapture it. I don't know, Ben, are you ready with the document?
I don't know if I see.
Are you on?
Oh,
Is
there
Ben
he
back
is.
from break?
He's logged on, but I don't see him.
Right, we can give him a minute while waiting for him. I also did want to check because we were looking at we were about a third of the way through the outline, but we did start some ideas came up that maybe made sense in other parts of the outline. I wonder if you think the way we started doing it works, of like looking page by page, or should we sort of like quickly scan the whole thing and then have like discussion time afterwards and go back and plug things in where they make sense?
You know, I think that moving forward with going through that, but having the ability for council to weigh in at that moment, because it would be fresh, rather than have to, I think would be appropriate.
Okay, sounds good. Yeah. Oh, Ben says back in a minute. It's logging back on.
He's on. Tell him he's logged on. And see.
We don't have it up, but did anyone have any thoughts that you remember about what we were talking about? Recall, we were looking at, mental health system of care, basically demographics, community-based systems, crisis, 5150 crisis, there it is. We made some edits there. Are there any other ideas for this section, or should we move on?
This is Councilmember Burt. I wonder if there's a way to capture, or it's kind of already innate in there, about the lack of resources. You know, we heard from numerous speakers today to talk about, in a perfect world, right? This is what should exist in the mental health. But I just want to make sure again that we're, you know, without sounding doom and gloom, but that, yeah, that we recognize that there's a lack of resources, that, you know, some of it's pilot, there's, yeah, lack of staffing. Just if we can highlight some of the issues there.
Yeah, so like in this section, here's an overview and here's some identification of what the holes are.
Right, exactly.
Yeah, and that probably applies to both this section and the next one that's going to focus similarly on system of care for IDD.
Exactly.
And I think if we looked at some of the different opportunities like the LAO or Little Hoover Commission or the state auditor, if they have actually delved into these as far as lack of resources or staffing, that way, you know, it might be helpful because it's been done by those agencies, and they could point out that what recommendations they had made, or, and then we could also look and see what evolved from the, if in fact they had that.
And I don't know if it makes sense to add it here or under the regional center section, but one of the areas that I think that we do see a lack of resources is for individuals who are duly diagnosed. It's a very small pool of providers who are willing to work with individuals who have developmental disabilities. We often hear that they're just not qualified to work with individuals with developmental disabilities, and so they're not comfortable doing that. So I think, I don't know if this is the spot to fit it or if it makes sense on the next page, but I do think that's something to address, because we know there's a lack of resources overall, and then you add on top of it someone with an intellectual or developmental disability, and it just exacerbates the problem in terms of not having those resources available.
Yeah, I see what Ben is doing in the document, and it was actually similar to what I was thinking, because we have mental health, IDD, and then we had a separate category for youth to look at kind of both, and maybe in between that we could have a like dual diagnosis, mental health, IDD, dual diagnosis, then youth.
Are we also calling out like Deaf Plus? And yeah. I don't know where this would go, but I thought I heard one of the speakers say something about Medi-Cal restricting funding or Medicaid restricting funding on trauma-informed care. Did I here incorrectly, which I could have.
And maybe go back up to funding concerns. Yeah. Yeah, and we can research any of these things and report back if we're finding a lot or not a lot on any of the suggestions. Any other thoughts on this section, or should we move on to the IDD and we can sort of come back to things that overlap?
I think in addition to the Medi-Cal trauma-informed care, I mean, when we look what, it's a political hot potato right now, but when we look about the ability for the possibility of Medi-Cal being cut drastically, what's plan B for this population? What resources will be afforded if there is a drastic reduction in funding?
This is Ben Conway. Chair Frazier, does number 6 capture the comment you just made? I just want to make sure.
It does. Very well. Thank you. Any other thoughts from our council before we move on to the next component?
Right, why don't we move on to the next, and we can always, ideas come up when they come up, so.
Sure.
We can bounce around the document as needed. Section 4, system of care for individuals with IDD, structured similarly as I noted before, focusing first on demographics, the prevalence of IDD, the different types that there are, any intersectionalities, co-occurring conditions, data to the extent we have it, Lanterman Act services, regional centers and other services, and services and supports resources for people living in the community.
I have two things. I almost wonder, you have services outside of regional center. I would, our stats show it's 20 to 30% of our population are not regional center clients. So I would almost make it its own Roman numeral instead of under regional center, to make sure that we know that there's a pathway for those families who aren't regional center clients. To see how it's under Lanterman Act Regional Center, Roman numeral 2, I think. Or yeah.
Councilmember Burt,
Yes.
I think I'm hearing you correctly, and I just want to make sure I capture it right, because I think developmental centers would be only for people who are regional center eligible, and then the state hospitals for people with IDD would almost really go under the new C for dual diagnosis. But then I think what you're saying is almost like this.
It's almost your number 3, services and supports who are non-regional center clients. Right, exactly.
Yeah.
And then I feel like this is really heavy with like group homes and support homes. And while those are important things, where's the proactive support, right? I think Christina was like, where's the resources before we get to group homes?
Yeah, and I want to offer to staff to be a resource in this area. I think our system has gotten increasingly complex over recent years. We actually don't have developmental centers available to us anymore, except through a criminal case. We have Porterville Secure Treatment Facility at Porterville Developmental Center. That's the only remaining developmental center. The facilities that you have under that, those are actually facilities that the regional center is going to oversee and refer to. So that those would not be under developmental centers. Those are community placements. So I would rework this a little bit, and I do want to, be cognizant of the fact that we know the community is going to be reviewing this, and make sure that we present it in a way where we're accurately reflecting the way that the system works, because our regional center system is unique in that it is comprehensive. It's an entitlement system. We guarantee that we are going to meet an individual's needs for their lifetime, right? If they qualify for services. And that's really unique, right? There's no other system in the country that's like it. And we don't have the same thing for mental health, right? So I think it's important to present the regional center system in that way, so that we show that it is a comprehensive system. Really, the only time that we're seeing individuals who are served somewhere outside of what regional center would be coordinating is either they're choosing to do that on their own, or there's court involvement, right? Something like a criminal case. But really, regional center remains involved, even if someone is at Porterville Developmental Center in the secure treatment because of a criminal case. Regional center still remains involved. They still have a service coordinator that's going to visit them. So I just want to make sure that we're reflecting that it really is, it's comprehensive case management and service coordination. We're even working with the schools to make sure that we are supporting them in accessing the school services that they need, all of those generic resources in the community. So I would suggest that we rework this section a little bit to highlight that that case management piece of it, and then potentially cover maybe the services that are funded through the regional center, and then the generic resources in the community through other agencies that regional center is going to support individuals in accessing. I would love to hear from others, Councilmember Libero, especially if she has any other thoughts on that, but that would kind of be my thought on this section.
Yeah, I think that makes more sense to me. I was a little bit confused with the organization here. I think the adult residential facilities, group homes, enhanced behavioral support homes could all go with the community crisis home C, and then just call it specialized residential. Maybe put those together. That it represents such a small amount of what's offered through the regional center system. I would cluster those and then spend more time talking about some of the other services, like Beth mentioned, with the like mobile crisis, preventative type services. Even emergency alert, swimming lessons, things like that might be relevant to where someone would intersect with law enforcement.
This is Ben Conway again. I want to make sure that I'm capturing everyone, but in particular, Dr. Libero, Councilmember Byrd, and Councilmember Petaruto's comments right now. So I've moved, as you hopefully see, the things as Dr. Libero just mentioned, up under specialized residentials, and renamed specialized residential services as Roman numeral 2, number 1, letter C, and then more Roman numerals. And then below, proposed moving up, services, supports, and resources for people in the community is the next thing that's talked about, and started adding some of those things that I think I just heard Dr. Libero say: mobile crisis units, emergency alert, swimming, for example. So I'm just wanting to check for my understanding, and to ensure that I'm accurately capturing the council's, the council's input.
I think this looks better. I'm still stuck a little bit on the developmental center one.
Oh,
So-
and I apologize. I added a note that's probably not visible now. That
Oh, there we go.
Porterville is the
Okay.
only remaining one, and it's only through criminal proceedings. So that would be probably, so that it doesn't just disappear, but also that it would probably be very
Be a
short.
little more specific. Okay.
I think we also, just as a parent advocate, we have to acknowledge that not all regional centers offer all of these, or they may be full, or there's just different quality. So there's not always equal access to these resources, depending on where the person lives.
Good point.
I think it's been mentioned also that the entitlement, and again, proudly the whole state is the only one in the country that provides this, but it's also at the will of the legislature to fund. With the years of cuts and freezes and non-restoration, usually our population is the first to get cut and the last to be restored. And so all of these depend on the economy, unlike Prop 98 for education. And so all of this can be reduced dramatically depending on the budget.
Great point.
Encourage you all. I think we should keep talking about this. But this section in particular is probably the area where there's the biggest gap between our expertise and your expertise. The council has lots of expertise in this area. We have far less. This doesn't have to be the only time we take in information that is leading us to adjust this outline. You can email us. You can't email each other, but you can email us with any suggestions, both about this organization or about good sources of information that you know of from your work that will help us in our research and writing about this section. But other thoughts about changes to make while we're here together on this section.
So I just noticed we have number 2 is, I think number 1 is regional center, and then number 2 is services and supports. So I just want to make sure that really should be under regional centers, if that makes sense. So services and supports and resources for people living in the community, that's all going to be coordinated through the regional center, right? If that makes sense.
Well, not always. It can be.
Well, so I guess that's a good point. Are we talking just services coordinated through regional centers, or are we talking
generic
other services? Yeah. So that raises a good point, because there are the regional center services, and then there might be generic resources as well that regional centers could assist families in accessing.
So are you kind of, as an example, referring to like behavioral ABA that the private health plans fund in lieu of? Okay.
Yeah, so something like that, or maybe it's ABA through the school district. It might be, counseling through health insurance. So I think we potentially maybe have 2 categories of services there. You have your regional center services, and then you have other services that are going to be funded by other sources outside of the regional center. we refer to them as generic resources. That's kind of the terminology that we use, where it's other agencies that are providing those supports.
And I see that Councilmember Libero has put up resources for us. Thanks.
Yeah, that's a great definition.
Need to see that? Do you need me to?
I'd like a record of it. You'll
Yeah.
have access to
Yes.
what's in the chat after,
Yes.
yeah. But I don't need it.
Okay.
In the moment, but to have it after for our records. would be
Yes.
great.
This might be out of the scope of what we're doing, but I'm just gonna throw it out there. I hear a lot from law enforcement that they get many calls from group homes. Are we gonna talk about the intersection at all of like where law enforcement's most likely, or the types of calls that maybe they're more likely to go on, like, you know, for group homes or eloping, because maybe our suggestions at the end will be tied to some sort of training for group homes, say, or school resource officers. Just throwing it out there.
I think we may have some of that in youth as well. Yeah, and you'll note, we put here that we've been looking into having some witnesses come in July to talk about youth issues. So this section is currently needs some more fleshing out. If anyone has, like if the folks that you're hearing about the group homes, have anything to say to us or refer us to.
Yeah, group homes actually would be more under the adults, technically.
Oh, okay. I'm thinking of foster care. But
Oh,
yeah,
no, yeah.
I thought I misunderstood you. Thank
No,
you. for
no,
clarifying.
that's a good idea though for foster care. I didn't think of those. Absolutely.
Just on that topic, I don't know that we've really covered it, and I'm trying to think about who would be the appropriate resource to cover it. But really, I think the issue with the group homes really reflects the lack of resources, because what we see happen is someone is in a group home, maybe behaviors are escalating or something is occurring where the home is really no longer in a good position to meet that individual's needs, but we may not immediately have somewhere for that person to go. And so it does become a very challenging and complex situation. So there's a whole conversation to be had there. And there is a lot of resource development going on. But I do think that is a challenge as well, because the other thing that we see happen sometimes is someone may leave and be placed on a hold, or someone may be hospitalized, and then because of their level of care, they may not even be able to return to that home. So now we have someone who's maybe in the hospital, and we have nowhere for them to go immediately when they're ready to be discharged. So just another one of those challenges in terms of shortage of resources.
This is Dag Ben Conway again. Councilmember Petarudo, does letter E there capture what I hopefully does, but capture what the point you were just making?
Yes, it does. Thank you.
Any further thoughts on this section for now, or do we want to move on and see what later sections have? All right, hearing none, Ben, why don't we move on to the next bit? We touched on a little bit on the systems of care for youth. Again, like I said, this is a small section because we're looking to expanding it more over the summer, but if people have, if anyone has initial thoughts about directions to expand, please share.
What about a directory of services that kind of acknowledges in an area where and how people can attain these? When you talk about like in Medi-Cal, they have, you know, a directory that doctors that accept Medi-Cal or whatever, but where we could have some kind of service directory that where people could access to readily help facilitate some of the needs or something like that. It's great to have all the programs, but if people don't know how to access them.
Yeah, and actually you saying that it is also like, we can be very comprehensive about these systems of care, and I think someone said something along these lines earlier too, just that
Yeah.
thinking about how it links with law enforcement. The issue is there's what services there are, but there's also, are there gaps in either law enforcement knowing what is there, some obstacle to them accessing it in the moment. So thinking about all of these different parts sort of through that lens. We don't want to totally go down every rabbit hole of all of these areas, which all could be their own report.
This is Dag Ben Conway again. I apologize. I am adding something that wasn't mentioned by the council, but under E Roman 4, new 4, I added crossover youth for youth who start in one system from foster care or delinquency and then cross over into the other, and well, it won't, which can happen in either direction.
You may also, the diversion, regional center has a diversion program. I don't know if you want to add that under possible resources. But it's for, I don't know, Lauren, you may know, is it for all ages or certain ages over 18? Or Christina, do you know?
So for the youth cases, there is what's called, it's IJCAT. I'm trying to think of what the acronym stands for. Interagency Juvenile Competency Assessment Team, I believe. And that can be ordered by the court where, and this is not just for individuals with IDD, but it's a tool that the court has available where there is a group of of representatives from all of the agencies that might have resources. So you have the regional centers, you have the school districts, you have probation, and you have behavioral health, social services, and all of the agencies come together and prepare a report for the court in terms of what services they might be able to provide to that youth to be successful. And that might include competency training. For the diversion, I'm trying to think if youth qualify. I have never seen it on a juvenile case, but we do see it quite frequently for adults. And that's just where the court orders regional center to make a recommendation as to whether an individual should be placed on a diversion plan, and then what that plan should include, what services and supports might be in place, what expectations for the individual. And then if they follow the plan, the criminal case is suspended. And then if they follow the plan, then the charges against them are dismissed at the end. But that would be for adult cases. So that would go up top. The other thing that we don't have much about, and I don't know how much we want to get into the process in criminal cases. The competency is the other thing where that comes up frequently on these cases. And then we're looking at competency training either in the community or at Porterville Developmental Center in the secure treatment.
Sorry, this is Doug Conway again. I have two questions. The first in reverse order is the one you just made on criminal cases. So I think I moved the adult back up and got the competency, but I just want to make sure I have that right before we jump back to youth. Is that right, Councilmember Peruto?
Okay, so I'm going to be really nitpicky about this language,
yeah,
but
please.
just because it's an issue that comes up frequently. So the regional center does not evaluate for competency. The regional center makes a determination whether the individual has a developmental disability. And then if the court determines the individual is not competent, then the regional center makes a recommendation as to how that individual should receive competency training. And I'm happy to provide you with more information and details on the law and all of that outside of the meeting.
I
Yeah,
appreciate it. And this is exactly why I wanted to ask that question, because I felt like it was more nuanced than I was capturing.
Yeah, thank you.
And then the interagency juvenile competency assessment, I think there was at least one more word that I missed.
Oh, team.
A team, oh.
Yes.
Thank you. And sorry to interrupt the council.
I want to flag too, we on the agenda, we have this agenda item set to end at 4, which we don't necessarily have to do. I think if we go over the end time of the meeting, there's nothing wrong with that, right? Okay. But also want to be respectful of everyone's time, since we set the agenda to end at 4:10, I think. So up to you all how much more time we want to spend on this. Should we advance in order to just sort of make sure we cover all the topics?
Can I add just one quick thing? I don't know, Christina, I don't know if that's considered regional center diversion programs is number 6, or the next one should be number 7 because they're different things. Is that correct? Or is it under the diversion program?
No, you're right. Yeah, we should just move that. There you go. Perfect.
Okay. And then I would add mental health court also. And that's, again, I don't know if that's for, yeah, adults only.
this is Dag Ben Conway. I'm just going up into the mental health section to add it in there for now, if that makes sense.
Yeah.
You'll see for the moment, I've made a comment, only adults or minors to capture Councilmember Burt's question within the comment.
Perfect, thank you.
Oh. Why don't we move on? And we have sections on police as first responders, sort of the history of that, and any research about what are the outcomes of police interactions with people with mental health challenges and IDD, sort of define the scope of the problem that's trying to be fixed.
Under traffic stops, or even the community, the issue of communication. I was thinking of the producers of Being Michelle when they were talking about what do you do if somebody, and I'd like to know what the law or most of the policies say, because I know it varies that some departments have access to a translation service they can pull up on the phone and some don't. So I'm curious what the law says. And I don't know if you want to put under effective communication, or I know some departments use premise history, some of them use blue envelope. You've got the translation issue.
Would this be a slot for registration or a registry?
I would call it I wouldn't call it a registration. I'd call it a voluntary
Yeah.
database or something.
I think we do have some blue envelope. You have it at least listed in alternatives later on in the outline as well. Any more comments on this section? Okay, I'm gonna move a little faster through the rest because Doretha is saying, Doretha, you can respond. Doretha has a little bit of concern about whether we run over the stated end time on the agenda.
Yeah, technically, you can continue, but you have to keep the meeting open to the public. I don't know, most places at 5 o'clock, the state buildings are closed. But if you haven't made arrangements for that, that poses a problem.
Well, yeah, we have to be one of them.
Okay.
So, yeah.
Okay, I mean, yeah. Because you stated that it was going to end at 4. There's no penalty if you go over, okay?
This section council meetings of witness materials, I think doesn't need that much discussion probably, because I'm just trying to list everybody. So currently, it lists everybody who's come to speak before today. So we'll continue slotting in the people who have come to speak. If people have thoughts about organizing it in some different way than we've done here, let us know. But I think there's less discretion of what it is, because we have chosen the witnesses already. Or I'm just reflecting who's come. And then moving on from there, then we have our training section and our non-training alternatives section. So looking at training first, and all of these, we have sections where we've got a literature review at the front. And then we have sections that are meant to take in all that we're learning through this process. So we maybe want to give some more attention to the literature review now, because the other processes will be, the other sections will be filled in as we get results a little bit more. So we can look both at literature review under section 6 training or section 7 non-training interventions.
Where are we going to put the summary of the survey that we distributed in?
We have, did I note it on this? We had talked about that, and I think it's been a little bit of an open question. Will we put it all together, or the survey does address multiple of these topics? So I think we were thinking that we would sort of be working in, once we get whatever report we get back from research, kind of look at it and split it up by and weave it into the sections where those responses are most relevant.
Okay.
But another approach would be to have a section that's dedicated specifically to the survey. It could go either way, and if folks have a preference, we can talk about that too. Any more thoughts of areas for us to research for literature?
Well, I think the non-training interventions, where would a school resource officer fit into this component? Because they're very valuable, and if they're integrated with the special education classes, I think that would be thank you. Wait.
Any other categories of literature we should be looking for?
Do we plan to include, like, we heard about some great programs today, like the Denver Star and programs in other states. And I see that we have the co-response alternative response models in California. Do we plan to look at models that may have been successful elsewhere?
Yes, that is a good idea. I think we didn't explicitly say that, although we have evaluation of models identified through literature review and identified through council process. So we can include it there, but or we could just also include oh yeah, you added elsewhere, that works. Any other areas to research? And I think these are good. Like I said, you can email us any additions to any of these sections. So I think continue to, you all know many resources. There's definitely a wealth of knowledge here. So dump whatever you want into this document that you have and send it to us, and we'll figure out how to work it in. As we've touched on all of the content pieces, I think the next step is just to approve the well, we need a motion from somebody at whatever. We can talk a little bit more if you'd like to, but if you feel ready, we could also if there is someone who wants to make a motion to approve the outline as amended, we can do that at any time that you feel it's time.
I'll move to approve the outline as amended and then to authorize DOJ staff to make changes as needed with approval from the chair and vice chair.
This is Vice Chair Zuniga. I second the motion.
Madam Parliamentarian, would you please take a roll call vote?
Discussion. Ask for discussion.
Oh, after the lengthy discussion, would you, anybody, discussion about the discussion? Hearing none. I would ask Madam Parliamentarian to take a roll call vote. Thank you.
I will begin the vote with Chair Frazier.
Aye.
Chair Frazier votes aye. Vice Chair Zuniga.
Aye.
Vice Chair Zuniga votes aye. Member Brazil.
Aye.
Member Brazil votes aye. Member Burt.
Aye.
Member Burt votes aye. Member Libero.
Aye.
Member Libero votes aye. Member Petarudu.
Aye.
Member Petarudu votes aye. Member Tingarides. Member Tingarides is absent. Mr. Chairman, there are 6 members present and voting. There were 6 ayes, 0 nays. Period.
So we have a quorum and an approval by the council to move forward. So let's move on to Action item 18, presenting the next meeting dates and setting next meeting agenda, or alternatively, delegating authority to DOJ to set next meeting agenda subject to approval by the chair and the vice chair. Staff?
They're waiting for you, Kelly.
She just moved to approve it and delegate. No, she does. I,
That was, that didn't. Okay, first, Member Pettigrew, could you restate what you moved?
Sure. Let's see, to approve the outline as amended and to authorize DOJ staff to make changes as needed with approval of the chair and vice chair.
Okay, thank you.
we're good. Sorry about that. Always want to be sure.
Yeah,
that
I
we've all
heard the
agreed.
first part, but I didn't hear the authorization, so I wanted to make sure that that was part of it, or else we'd have to vote for it. You did, you were fine.
Perfect.
I'm sorry, and we were talking, we've moved on to 18.
Yes, we have.
Yes, and so, also recalling last time, we had, already given to us authorization to set dates. We didn't give authorization to set agendas. So I'm reporting back on dates, and the report back is actually that we haven't heard from all of you about your schedules. So we haven't been able to choose a date yet for the July meeting. So this is the update is just a nudge that if you haven't yet gotten back to us with your schedule for the remaining meetings, please do so, and we'll send out some options by email once folks do that. And we do need authorization to set the agenda for the July meeting. Hopefully, as usual, working together with the chair and vice chair, if anyone is willing to make that motion.
Any comments from the council and discussion on item 18?
This is Member Burt. I move that we delegate authority to Department of Justice to set the next meeting agenda, subject to the approval by the chair and the vice chair.
Member Libero, I second the motion.
First and a second. Madam Parliamentarian, would you please call the roll call vote?
Hearing no discussion, we will move to the roll call vote. I will begin with the chair. Chair Frazier.
Aye.
Chair Frazier votes aye. Vice Chair Zuniga.
Aye.
Vice Chair Zuniga votes aye. Member Brazil.
Aye.
Member Brazil votes aye. Member Burt.
Aye.
Member Burt votes aye. Member Libero.
Aye.
Member Libero votes aye. Member Pettigrew.
Aye.
Member Pettigrew votes aye. Mr. Chairman, there are 6 members present in voting. There were 6 ayes and 0 nays.
Thank you. So that item moves forward. Move on to, pardon me?
Motion passes.
Motion is passed and move forward. We'll move on to 19, which is a discussion item. Just going to say thank you to everybody who's attended the meeting today, and to our panelists and to staff who's done an amazing job again on dotting the I's and crossing the T's for us. And with that, I am going to entertain a motion on item number 20 for adjournment.
Is Councilmember Libero, motion to adjourn.
The first, second, please.
Councilmember Burt, I'll second.
We have a first and a second. Any discussion on the adjournment? Hearing none. Madam Parliamentarian, let's take that roll call vote, please.
Thank you. I will start with Chair Frazier.
Heck yeah.
Yes. Vice Chair Zuniga.
Aye.
Vice Chair Zuniga votes yes. Member Brazil.
Aye.
Aye. Member Brazil votes aye. Member Burt.
Aye.
Burt votes aye. Member Libero.
Aye.
Libero votes aye. Member Petarudu.
Aye.
Petarudu votes aye. Mr. Chairman, there are 6 members present and voting. There were 6 ayes, 0 nays. Your motion passes.
Thank you. That item has been approved. We are adjourned. See you in July. Thank you.